Thanks for joining us today, everyone. We're excited to kick off our Analyst Day, which is aimed at helping the financial community better understand Clover's unique business. Today, you'll learn about Clover from the executive leadership team, see a demo of the company's technology platform, the Clover Assistant, and hear from a panel of physicians who use the Clover Assistant in the field every day. Before we get started, please review the disclaimers included here and refer to this as a guide for today's call. For this meeting, we ask participants to display their first and last name on their virtual name tag. We will have a Q&A session at the end of the presentation. Please use the raise the hand feature to be added to the question queue. On the call today are Vivek Garapalli, CEO, Andrew Toy, President and CTO, Joe Wagner, CFO, Sophia Chang, Chief Clinical Informatics Officer, Mark Spector, Chief Medical Officer, Kumar Dharmarajan, Chief Scientific Officer, and Chamath Palihapitiya, CEO of Social Capital, will be joining us for Q&A. While we are all settling in, and before I hand things over to Vivek, here's a short film about the Clover Assistant to open the day.
In many cases, information is spread out all over the health system.
I certainly expect my primary care physician to have access to all the pieces.
The evidence-based guidelines and recommendations are changing all the time.
A couple years ago, I had surgery and I was inundated with paperwork.
The voices of doctors and patients. They were our inspiration for the Clover Assistant.
You go to your doctor, he's on a treadmill every 15 minutes, he's got to get another patient in.
It's very common for me to have patients with 3 or 4 active chronic conditions.
There wasn't continuity of care, and then you end up not getting the care that you were looking for in the first place.
And it was like, okay, now I just retired and you're going to do this to me?
The Clover Assistant is a web application, and a physician uses it every visit that they have with one of our members, and it's tuned to show them clinically useful, personalized, relevant information that helps them give better care during that visit. So what we can do is match every patient's individual data, because we've pulled it all together, with all of these clinical evidence-based protocols that are coming out all the time. And now for every PCP visit, every doctor visit, that PCP is seeing exactly the information they need to, and technology is powering all of that.
I was taking a pain medication that reacted badly, and I ended up in the hospital.
I go and see my physician, say, oh, gee, why are you here? I said, are you aware I was in the emergency room?
If the data that I have about a patient is not up to date, then I could be making a medical error.
The way that our technology helps specifically is to personalize the care for every single member. So we're not just saying across the board, treat everyone the same. Everyone is different, and technology is really good at bringing that difference to the surface and personalizing care.
The information is really set up for me in an efficient way within the program.
It means that I'm providing better care, and it also means that I have confidence that I'm really providing that better care, and patients feel that.
We see this as a way that we can make the whole system more efficient. It's a huge bureaucracy around doing paperwork and filing claims and checking insurance. So if we can take that inefficiency out of the system, power it with technology, help physicians give better care, we can take that and actually make healthcare more affordable and at the same time give better benefits and better outcomes.
Clover Assistant really creates a conversation between the doctor and the health plan through the technology. And I think doctors feel more respected when it's a conversation than when a health plan just says, you need to do this or that, because when health plans do that, they're often wrong.
A lot of times we get questions where they say, well, physicians don't use software. And we're like, no, they want to use software. We live in a technological world at this point. We've just been giving physicians bad software, unfortunately. We have a way of informing and educating and engaging with any PCP. We scale at the speed of software.
It is such a delight to have all the information I need right there in front of me. and then I feel great about the care that I'm providing my patients.
Clover Assistant is being used by physicians. They enjoy using it because it's built for them, and they know that when they use it, they are actually helping take care of a senior better than if they weren't using it.
Great. And with that, I will now turn the call over to Vivek to kick things off for us.
Thanks, Whitney. Thank you, everyone, for joining us today and giving us a bunch of hours of your Friday. We really appreciate that. Hopefully, you have all gotten a chance to dig into the overview deck that we shared upon announcement of our deal, and also the deeper dive deck that was shared yesterday. Today, we're going to use that deck to walk through Clover in further detail. Given that some of you are coming into this conversation from a technology and software background and not necessarily a healthcare background, I'm going to briefly walk through some of the higher level aspects of healthcare to begin. Apologies for those who are steeped in all the details of healthcare already, as I know many of you are, so appreciate your patience. Just in terms of agenda, we're going to walk through more details behind each step of the flywheel that drives our Medicare Advantage offering, which we sometimes refer to as MA. I'm going to then turn it over to Andrew, our President and CTO, whom you just saw in our video, and our CFO, Joe, to describe how MA is only the start of how we intend to scale our technology platform. Then we're going to have our clinical leaders, Mark and Sophia, walk you through a demo of the Clover Assistant, as well as a panel Q&A with a few physicians that use the Clover Assistant every day. And then we're going to wrap things up with Joe, who's going to give you a deeper dive into our historical and projected financials. And as always, we're going to leave plenty of time for Q&A. And again, all the materials we're going through today, you already have access to. Hopefully, you've had a chance to review. So just jump into the next slide. So it's not a big secret that healthcare is completely broken on many, many levels. And this is the problem that we founded Clover to solve. Just by way of background, I've created businesses initially on the services side of healthcare, then on the technology side, spanning outpatient services, hospital care, revenue cycle, then oncology data and now Clover. So with that, we'll get started. So we believe it's vital for individuals interested in Clover, currently invested in Clover, or thinking about investing in Clover to align around the content of this slide. There are core components of our mission, strategy, and thesis, and underlying data that one must believe to be true for Clover to be successful long-term. If one does not believe all of these components, that individual should not invest in Clover. So just to kind of restate, our mission is to improve every life. Our stated and consistent strategy is centered around deploying the Clover Assistant far and wide across all primary care physicians with really a fundamental problem we're trying to solve, which is to, one, improve decisions that physicians make, and to reduce variability in clinical decision-making. So in terms of the fundamental construct around the Clover Assistant is, does one believe that Clover Assistant allows that to happen? The second component is the thesis as to, does one believe that the Clover Assistant actually drives in a moat-like fashion incremental clinical and economic value? And we'll go through data to support each of the prior two statements as we dive in further. The third is, does one believe that if consumers have access to plan choices where one of the plan choices is of lowest cost, most benefits, and widest physician choice, is that the plan choice that consumers will make the majority of the time? And you'll see that in data that we'll share around our established markets. And then on the physician side, do physicians want fairer payment and easier access to payment? And also simplicity in terms of their decision-making. And then does the government want lower costs? And these are, on the surface, obvious to us, but these are core tenets of our thesis that one must believe for Clover to be successful. And then the last component that one must believe for Clover to be successful is, can the Clover Assistant be applicable not just in Medicare Advantage, but across all of Medicare, as that is our actual total addressable market that we're attempting to serve. So just in summary, our strategy is on its surface very simple. It's scale Clover Assistant, drive more value through Clover Assistant, give a meaningful amount of that value back to consumers and the government, and then just keep repeating 1 through 3. So we started to build this company. Our goal was to not just build a better insurance company or a better Medicare Advantage insurer. We became a Medicare Advantage insurer because it offered us two ingredients that we think are key to scaling successful technology companies in the healthcare space. One, direct access to longitudinal personalized data for patients that are actually in need of care management, helping us maximize the impact of our technology. And two, clinical and economic alignment with our constituents, consumers and physicians. A byproduct of our selection criteria was finding one of the most sizable and fastest growing markets in the world, Medicare Advantage, and also all of Medicare. So just to level set on the flywheel, our virtuous growth cycle, step one is capturing and synthesizing the broad set of data that's available to us as an MA insurer. Step two is leveraging this data and using our technology to drive personalized insights on how to improve the delivery of evidence-based care. Step three, which is possibly the most important step, is getting a broad base of physicians to actually use our platform and make more informed clinical decisions. Step four comes naturally after that, as physicians use the actionable data available to them at the point of care to make better decisions. Everyone benefits. This provides us with expanded margins that we share back with our consumers in the form of lower cost plans and more access to care, resulting in step five, growth. Consumers care about value. MA is not unique in this capacity. When you deliver more choice at lower cost, you generally will win in any consumer-driven market. So just going through each of these steps in more detail, we start with our data platform. As mentioned earlier, we chose to be an MA insurer in part because of the breadth and depth of data we have access to, including claims, lab results, EHR data, and pharmacy data. By starting an MA plan, we focused on centralizing and synthesizing these distinct data sets so that we could create personalized views of our members, including predictive models. These two components are already very hard to do, but we go a step further in what we believe is truly our differentiation: provide actionable data to physicians at the point of care to assist them while they are seeing Clover members. And we do that via our software platform, the Clover Assistant. Because we're software driven, we can expand Clover Assistant coverage to any physician in our wide network and deploy our insights at scale throughout the already existing healthcare ecosystem. On the left here, you'll see how we believe we are positioned in terms of data access and actionability relative to other key players in the healthcare space. Again, we're not the only ones pulling together patient data. Other payers have built EHR integration or single chart views in the past. What we believe is our moat is our ability to drive action and insight based on the data, and our ability to do this with any provider in the ecosystem, not just a subset of a narrow network of physicians or employed physicians. On the right, you'll see some of the key value drivers our platform is able to provide physicians. And you're hearing more about these from Sophia during the demo. But what you see right now are high-level things like evidence-based protocols, where we map personalized clinical data to a registry of clinical evidence to flag when our members are off evidence, so physicians can adhere to the standards of care when appropriate. Then there's early disease detection, where our machine learning and clinical rules surface conditions that may not have otherwise been identified. The key here is that this information is surfaced to physicians at the point of care so that they can develop care plans that actually treat these conditions. Then there's care coordination, which captures a lot of what we'll be working on for the near term. We think there's a large opportunity in getting members care in the right settings, and we believe the Clover Assistant drives tremendous value in helping physicians optimize that. Given the demo we'll be walking you through, we can skip through the next few slides. We've included them so you can all get more intuition on how the platform works after this session. So I'm going to just briefly mention a little bit around our ML models. Our ML models driven by the Clover Assistant help physicians to capture diseases at an early onset stage. Right now, we have highly functional models built for 25 specific conditions. We're continuing to build out our large set of disease models, but what we're most excited about is the fact that we pair our ML prompts with actual care planning. In other words, our ML isn't meant to generate more fulsome documentation, but to generate actual care improvement. This helps us in two ways. One, we know that care plans generally lead to better outcomes over the long term. This is really the main thesis and supported by our underlying data that we will be going over shortly. And two, as a byproduct, we get more accurate revenue given MA's risk-adjusted payment construct. Again, we'll be showing that with our underlying data we'll be going over. So now that you have a bit of of intuition on what the Clover Assistant platform does, let's discuss the most important part, physician usage. We believe the Clover Assistant is a compelling platform for physicians for a few reasons. One, it's a standalone platform outside of the low NPS EHRs that we believe is easy to use and provides clinically useful content, as we just discussed. Two, we pay providers an enhanced rate at about 2 times the fee-for-service Medicare rate, and we make that payment extremely rapidly. What's very important about our payment model is that it is fixed. When you're a physician, you're now not taking on potentially unsustainable financial risk as you may in other payer arrangements. We believe we've created a very large moat with respect to scale, as this allows us, we believe, to plug in and work with any provider, not just those sophisticated enough to take on risk. We believe this is also supported by our very high close rate, with which with respect to physicians opting into our direct contracting partnership arrangements, which we will dive into shortly. These 2 reasons serve as the activation energy to get physicians excited to contract with us and engage with the platform on an ongoing basis. Because of that, we've been able to scale this platform broadly and rapidly with contracts with over 2,000 primary care physicians and a myriad of different practice types across all 34 of our current markets. What you see here is a small representation of the statistics we track for the Clover system. So just to go over some of these key statistics. So 92% is the percentage of members or a percentage of visits where onboarded PCPs used the Clover Assistant for eligible visits in 2019. So one, extremely high engagement rate, and almost 60 NPS, which is unheard of in software used by physicians. And our software is not just used by sophisticated providers or large IPAs or health systems. 68% of our physicians are actually in practices with 10 or less physicians. And 11% of physicians on Clover Assistant don't even have an EHR. So that in that 11%, physicians are using Clover Assistant in many cases as their only software platform. Just in terms of payment simplicity, on average, we're paying physicians on the Clover Assistant within 4 days. So these physicians are now not encumbered by the 22 different E&M codes that they typically are billing other MA plans. And just from a clinical perspective, over 11,000 care plans are managed by the Clover Assistant per month on average. 2,000 medication adjustments are not only prompted, but also accepted per month by physicians on average on the Clover Assistant. And beyond that, and we'll talk about this a lot today, I referenced this earlier, there's almost a full, on average, 1 net new diagnosis confirmed by physicians via Clover Assistant. And this ties into the gross margin side as well. So we've generated an 1,100 gross margin differential in MCR, i.e. medical care ratio, or the inverse of that is our gross margin. So an 1,100 basis point differential in gross margin for members who see a physician on Clover Assistant versus those who see a physician not on Clover Assistant. And so here we've also shown just on this slide, there's 2 main points here where we can provide better support for a member base during unprecedented times. So we built telehealth capabilities directly into the Clover Assistant within a matter of weeks earlier this year. That's allowed us to keep preventative care visit volume during COVID roughly flat for members that see a Clover Assistant-enabled physician. But an additional vital statistic is the primary care visit rates are higher for members seeing a physician on Clover Assistant versus those who see a physician not on Clover Assistant, around an 8% differential, 1.2 versus 1.1. As I referenced on the prior slide, the Clover Assistant is able to surface almost 1 incremental diagnosis and associated treatment plan that is then confirmed by physicians. Not surprisingly, we believe this naturally leads to more intense care, hence the higher visit rate, as members do not necessarily know which physicians utilize and don't utilize a Clover Assistant. So we believe the higher visit rate is naturally physician-driven. I'll walk through shortly why that is vital. So when physicians use our platform, what does that ultimately do for us? Let's start with our most complex population. As is typical across all of MA and all of Medicare, there's a small high acuity percentage of the population that drives a significant portion of costs, which we call our complex care members. Payers typically vendor out management of this population to companies like Oak Street, Iora, and ChenMed, While they've all done a nice job lowering costs for the system, we believe we've created a much more scalable approach with similar impact. That's because, one, we leverage our closed feedback loop with physicians to figure out who is most appropriate for the program, as opposed to using latent claims data, including not just those who are already high risk, but those who are also of rising risk. Two, we engage members via their own physicians. So it's not a confusing conversation where we're trying to steal members from their physicians. Three, we use a home-based approach, which gives us more scale and efficiency when compared to brick and mortar models. We believe we can continue to achieve significant savings already evidenced by historical data across a larger base of this population. It's important to note that due to the traditional vendor-payer partnerships of the prior mentioned companies, there are potential challenges to getting business alignment around managing patients who are of rising risk when the patient's higher future predicted costs are over the next 12 to 24 month period. Clover, by having a scalable complex care program internally that is wholly owned, is untethered from that complex potential conflict of interest. Next, we'll walk you through the broader impact the Clover Assistant is having on our economics. Before doing so, I wanted to level set that we measure the impact of our platform by comparing medical care ratios, again, the inverse of that is gross margin, for Clover Assistant powered physicians to those physicians that are not yet powered by the Clover Assistant. So here you'll see an 1100 basis point gross margin differential across the two populations I just mentioned. This resulted in an 82% MCR for Clover Assistant returning members in Q1, our final pre-COVID period. As a reminder, this 82%, which we view as in line to slightly better than industry figure, is as a 3-star plan with better than competitor benefits. Just to frame that up a little bit, we've included an illustrative comparison point so you can see the general magnitude of what our 82% would look like if we took the theoretical max value, if we were rated at 4 stars to the bottom line and priced our plans like the next cheapest competitor in our markets. We believe this could be as low as 64% for Q1 2020 on a pro forma basis. Of course, as we expand margins, we'll end up sharing some of that back with consumers in the form of even better plan designs, but it should give you a good sense for the upside on an illustrative basis. And these results are after only 18 months since launching the Clover Assistant. Joe's going to go through this slide in more detail shortly, but the main point of this slide is to go into gory detail around what Q1 2020 looks like on a normalized basis. And just as an illustrative example around Q1, if you just look at Humana's 2019 Q1 medical loss ratio of 86.2 versus their full year of 85.6, Q1 in MA is generally a very appropriate measure of full year performance. And while the 1,100 basis point improvement and 82% headline numbers are impressive, we are far from satisfied as we believe there is meaningful upside ahead of us for our members. As of now, about 2/3 of the 1,100 basis point improvement has been driven by enhanced revenue from better disease burden capture. Again, this isn't about more meticulous admin tasks like diagnosis recapture. Instead, it's about using technology to identify diseases that exist earlier on and treat them. Thus far this year, we've identified more than 22,000 diagnoses for treatment via our technology's ML and clinical rules that were otherwise undetected. The other 1/3 has come from actual improvement in medical expenses. The key stat to highlight here is the 1,900 basis point improvement for our in-home care population, which is driven predominantly by cost reduction and lower acute events. Over time, we think the improvement for medical expenses will expand and overtake the revenue enhancement, but we know that does not happen overnight. As I referenced earlier, we believe this is strong evidence as well of the benefit of a higher primary care visit rate for those in need. We're also continuing to build what we know is a relatively early stage platform. In the medium to long term, we believe you're going to see key features like site of service optimization and referral management to help further bend the cost curve and improve our unit economics. We also think we'll be able to improve our unit economics via stars. As you'll see in this illustrative roadmap, we did not focus much on stars related features in the Clover Assistant until the second half of 2019. Given the time lag on stars, this means that none of the star ratings you've seen publicly have been impacted at all by the Clover Assistant. Unfortunately, in the wake of COVID, some stars gaps may be more difficult to address in the near term, given stay-at-home orders, but we're continuing to build upon our stars features in the Clover Assistant and are confident that we'll be able to capture the upside that we highlighted a few slides ago. As described earlier, we believe there's approximately 1,000 basis points of gross margin upside just in stars alone. So now that we've talked about high-level economics, let's talk about how we grow. At the end of the day, we believe consumers care about two things primarily. One, do I have open access to see a broad array of physicians? Two, does this plan cost me a ton of money? What you've seen in MA over the last 20 years or so is a divergence between PPOs and HMOs. PPOs offer the access that consumers want, but at higher prices. HMOs offer the low cost that consumers want, but without the wide access. Given the economics we've been able to capture with our scalable platform, we're able to offer the access of a PPO at lower than HMO costs. And importantly, we believe this is very rare in the industry. A Clover member can see physicians out of network at the same cost sharing as physicians in network. This creates the two-sided marketplace for us that allows further prospects for adoption of the Clover Assistant. So always be wary when you see PPO plan statistics. Focus also on the differential of cost sharing between in-network and out-of-network, as many HMO plans effectively masquerade as PPO plans. In quantitative terms, that means 17% cost savings for consumers when compared to the next cheapest competition, which are HMOs that offer more restrictive choice of physicians. We believe our great plans put us in a position to take advantage of the secular tailwinds that we're seeing in the market. As mentioned earlier, MA is growing at a 14% revenue CAGR and is expected to have 34 million members by 2025. This means the individual non-SNP market, which we currently focus on, will likely have somewhere in the order of 24 million individuals. We shared in our original presentation that we've been able to take 50% of the net new membership growth in the individual non-SNP market in our established markets. That dynamic gives us a lot of confidence as the market gears up for extremely rapid growth over the next 5+ years, particularly in 2023 and beyond. That take rate has helped us build an extremely strong position in our established markets. With 25% market share, we've been able to compete and take share from some of the largest incumbents across rural, suburban, and urban markets. What's important to understand is that while we're building and scaling the Clover Assistant, we have limited our focus on expansion, sitting currently in only 34 of the approximately 3,000 US markets today, and focusing most of our efforts within our 13 established markets. This transaction puts us in a position to rapidly expand in the 2023 plus timeframe by adding millions of Medicare eligibles to our addressable population in the medium term. So to summarize the flywheel, we scale technology to get better outcomes and economics. Then we share those economics back with consumers to get more and more members onto our platform. We believe this virtuous growth cycle will give us a scalable, large, and enduring advantage in the Medicare Advantage market. But what we're most excited about is the fact that our MA flywheel represents the first use case for what we're truly building here, a platform. So now I'll pass it over to Andrew to discuss that in more detail.
Great. Thanks, Vivek. And hi, everyone. For those of you who haven't met me before, my background is in technology. I'm a Stanford-trained computer scientist and engineer by background. Prior to Clover, my previous startup where I was CEO was in enterprise mobility and was acquired by Google. That led to me running the enterprise Android team where we built and shipped mission-grade code to billions of users. Vivek and I came together in order to disrupt the archaic healthcare industry through the development of a powerful software platform. I came to a health plan because I truly believed, and I continue to believe, that there's no way to build truly transformative healthcare software if you have to sell that software to today's payers and providers. Instead, you have to build and operate that technology inside the healthcare value chain, and that's what we do with the Clover Assistant. So what we're building here is not a Medicare Advantage company per se, but a technology platform designed to drive personalized, data-driven care, resulting in better outcomes at lower cost. And we think that our platform can be used with a myriad of business models. At the end of the day, our true goal is to simply get more lives under the management of the Clover Assistant with no bias toward any particular program or business model. So today, I'm going to talk a bit more about the next application of our platform after Medicare Advantage, direct contracting. For those of you who are unfamiliar with direct contracting, it's essentially a new government program from CMS's Innovation Center, CMMI, that allows private entities to take responsibility for the cost and care of beneficiaries in original Medicare. So around 40 million people today. We expect to launch our direct contracting entity, or DCE, in April 2021, so next year, where we will take full risk for the lives assigned to us. The program is particularly interesting to us because at the end of the day, original Medicare really just represents the widest network PPO out there. And given the Clover Assistant's impact in a wide network PPO, which Vivek talked about, which we view as very differentiated, we have a lot of confidence in our ability to compete in this new program by extending the Clover Assistant platform. Said differently, physicians will be using the Clover Assistant to care for Medicare eligibles, whether that member comes to us via MA or via DC. So in DC, physicians will have the same features we've built to date. And as we continue to build out the platform, all physicians and members across DC and MA will benefit. To get lives assigned to our DCE, we contract with physicians to be part of our entity exclusively. That is, they can only align to one DCE, but they can continue to work with other payers for other programs, such as Medicare Advantage. And providers are contracting with us, we believe, because of the similar value proposition we just walked through in Medicare Advantage, offering the Clover Assistant to support care management and an opportunity to get paid more for primary care without taking any financial risk. And we believe the strategy is a unique moat whereby we can plug into existing practices to quickly scale and capture lives in an asset-light manner versus having to stand up new practices and then having to attract members to a new PCP. So on the right, you can start to appreciate how this program is expected to immediately give us access to significantly more lives with each provider contract. So what's exciting here is that DC provides us with a faster and simpler way to grow lives on our platform. And by lives, I mean individuals whose care is managed by a Clover Assistant-powered physician. So in MA, we need to engage in two separate steps to grow lives under Clover Assistant management. One, a B2B step where we need to attract physicians to use the platform for their patients as we build our network. And two, a B2C step where we need to market and work with brokers to attract eligibles to our plans. Once we do those two things, we have lives managed by Clover Assistant. By contrast, in direct contracting, we can get significant lives immediately attributed to us via claims alignment just by doing the step one, B2B contracting with physician groups. We can then seek further upside through B2C activity by voluntarily aligning individuals who see physicians we have contracted with, but do not have enough claims history to count as claims aligned. And so you can see the effect of this here. In just 10 months through COVID, the Clover Assistant value proposition has led us to an expected 200,000 lives for 2021 and an estimate of over 500,000 lives for 2022. And by definition, 100% of these lives will be going to a Clover Assistant-powered PCP. With a small contracting team, we've been able to sign on over 1,500 physicians across 8 states, 3 of which we don't offer MA plans in today. And through these efforts, we've already built a pipeline of doctors interested in our DCE for 2022, and we have confidence that we can continue to add hundreds of thousands of lives under management. And due to the strong interest and momentum we're seeing, we've increased our estimate of covered lives in direct contracting from 450,000 in 2023, when we had first announced this deal, to instead 500,000 in 2022. Taking a step back then and thinking through our expansion plans holistically, we believe DC will be synergistic to MA. We believe we can quickly launch DC across the nation, and as we contract with physicians, we automatically bring lives under Clover Assistant management. We then plan to identify markets to launch MA plans based on the number of Medicare eligibles, where we see an opportunity for plan differentiation and geographic synergies. We believe we can leverage our DC relationships as a start to building our network and then launch obvious plans to drive MA membership. And lastly, we intend to continue to develop network relationships to support lower cost and wider choice for our Medicare Advantage members and lower costs for our DCE. Because our platform is designed to manage 100% of the Medicare population, as opposed to just the 1/3 that's in MA, we believe we'll have a unique advantage to contract with service providers and scale our platform's direct-to-consumer offerings. In other words, we believe our ability to scale across all of Medicare via our platform strategy will provide synergies across MA and DC. Ultimately, we believe our focus on open networks and software-driven care management makes this playbook amongst the most scalable in all of healthcare. So now I'll hand it to Joe to give you a walkthrough of the economic structure.
Great, thanks, Andrew. For some quick background on me, I joined Clover about a year ago after spending much of my career in healthcare finance at organizations like Bravo Health, Cigna, and most recently, United Healthcare. When evaluating the opportunity to join Clover, I was very impressed by Vivek and Andrew's vision, and more importantly, what I view as a true utilization of technology in a payer setting. So when we think about the expected economics and the flow of funds for our direct contracting program, it should be noted that CMS is still finalizing some of the economics of the model, but the best way to think about it is, based on the data that we've seen for the members that we expect to enroll, we anticipate that the benchmark of costs for the direct contracting program will be roughly the same as our blended revenue PMPM on the Medicare Advantage side. So to make it simple, let's call it $1,000 per member per month. Obviously, there are different components to each of those amounts, since Medicare Advantage has a mix of higher risk adjustment for now and additional benefits as compared to the direct contracting benchmark. So kind of keeping on the MA side for a minute, our target MCRs are in the 82 to 83% range over the long term. We have the ability to help manage cost levels through some traditional managed care levers, again, utilization management, pre-auth, payment integrity, et cetera. And then from an operating cost perspective, we're currently at about a 20% OpEx ratio as a percent of premium, with significant expenditures included in there for growth, such as broker commissions and other sales commissions, and other typical health plan functions, such as claims processing and enrollment. But we'll work to decrease that percentage over time as we gain scale to 11 to 12% of premiums. So this ultimately results in a steady state 6 to 7% margin on the Medicare Advantage side. So now let's kind of shift to direct contracting. We expect the initial level of medical spend for those direct contracting members against the benchmark to be higher as a percentage, at least initially, given that some of the traditional levers of managed care cost containment are not present. However, through the Clover Assistant, as Andrew mentioned, we're developing and putting into production certain features of our software that we believe will help doctors bring down the cost curve in areas such as shifting inpatient admissions to lower cost, more appropriate levels of care, such as observation stays, prevention of readmissions through tracking of ADT feeds with prompted physician follow-ups, using home health to offset expensive SNF stays, recommending certain post-acute facilities for which we have negotiated favorable rates, referring to certain efficient specialists, and then ultimately enrollment in in-home complex care for those members that are eligible. So this software-based decision support is in addition to the clinical value we already provide through Clover Assistant that Vivek mentioned and that Sophia will walk through with you in the demo. And you'll note here on this slide that we believe there's upwards of 1,500 basis points of cost savings opportunity here, and perhaps more, given the inefficiency that's in the fee-for-service system today. Now, we're not projecting that we're going to achieve that level of savings. We just want to note that we believe that it's out there as an opportunity. So as we think about our operating costs then on the direct contracting program, we anticipate that they'll be substantially less than what we incur on the Medicare Advantage side, because our CAC should be minimal, our acquisition costs, and our health plan functions like claims payments are not applicable. So we believe that nearly all the cost savings that we can manage against the benchmark after the CMS discount will fall to our bottom line and ultimately allow us to share those savings with providers, which will then drive even more growth. So here on the next few slides, we'll give you a quick preview of what we expect the physician will see when we refer to some of these levers for success. Please note that this page and the two that follow are design concepts and not yet in active use today, so the final product may differ a little bit from what you see here. This page shows how we expect to support referral management. We intend to provide this functionality for various types of referrals. So what we can do here is save costs compared to original Medicare by leveraging the number of lives under management to negotiate improved rates compared to Medicare, which will make an immediate impact on cost. On this slide, for example, we're highlighting labs as an example. So next slide is another example illustrating support for finding specialists. Beyond rate negotiating, we can use our engagement at the point of care to refer to more efficient, higher quality specialists and therefore improve long-term outcomes and costs. And on the next slide here, our partner physicians would target members with multiple chronic conditions who benefit from in-home care. And we believe that's roughly 3 to 5% of the overall population. So to get somewhat granular, these members are very high cost with an average medical cost of between $2,500 and $3,000 per member per month. In Clover's MA plan, we've been able to achieve a 1,900 basis point reduction, as Vivek mentioned, in MCR, and that's all on the MedX side. And we see similar, if not greater, opportunities for this program for direct contracting. So from a quantification standpoint, if we assume total eligible population is roughly 3 to 5% at $3,000 PMPM, saving 10 to 15%, that's worth 1 to 3% against the total MedX benchmark. And again, that's just one component of our overall strategy to manage costs for these members. So on this slide, to summarize the economic profile, we have this contrast for direct contracting against MA. One thing I want to highlight here, and this will help from a modeling perspective, is while the measurement benchmark will be similar, we anticipate that only a portion of that benchmark will be paid to us and will be accounted for as revenue, and that's dependent on certain downstream provider arrangements, such as with our partner primary care physicians. And this is based on the accounting guidance that we received by looking at the details of the program. So we anticipate that to be approximately 5% of the overall benchmark in our first performance year starting in April, but we do anticipate that will increase, that percent of benchmark will increase steadily over time as we execute more provider partnerships at scale. So the easiest thing to do is I'll give you a simple example. For one member, our downstream provider arrangements, mainly primary care with some discounts on preferred providers, let's say those are worth about $50 per member per month, of the $1,000 benchmark. Now let's assume, so that $50, we record that as revenue, and then we have corresponding medical costs where we pay that money to our provider partners that are about the same. So about 50-50, $50 in both cases. Now let's assume that we achieve 4% benchmark savings, which is roughly worth about $40. After remitting 2% of that back to CMS, our net savings is about $20, which is recorded as revenue. So what you're left with in that simple scenario is a $20 gross margin, which is about 2% of the overall benchmark, but it's a 29% margin on the revenue that we've recorded. So while our ultimate steady state margin is still to be determined for direct contracting, hopefully that gives you a helpful framework, both the mechanics of the P&L as well as the overall economics that we expect to achieve from the program. So now I'm happy to turn it over to our clinicians who will show you a video demo of the Clover Assistant and how it is used by our physicians.
Hi, I'm Dr. Sophia Chang, and I am the Chief Clinical Informatics Officer here at Clover Health. And thank you for joining us and get the chance to show you how our Clover Assistant tool works. And so I'm really excited to present to you. So this is what I would see as the primary care doctor in my office. My office staff would have actually seen that Todd Black is on my schedule and will have started the Clover Assistant visit for me. When I sit down and I've got Todd next to me and we're talking through his medical history, et cetera, and his chief complaint, this is what I'll have open at the same time as I have my EHR open. Here, what we do is Clover does prompt about COVID-19 symptoms, which is something that we do ask right now during the COVID pandemic. But the tool generally starts with the diagnosis section. And here, what we'll do is we will look at a couple of key and important diagnoses that Todd has. In this case, since it's required here, we've got chronic kidney disease, where I haven't noted that before in the past, but Clover surfaces up to me all of the relevant recent lab information that Todd has had that confirms that he indeed does have stage 3 chronic kidney disease. And it just is a reminder for me to document that and to remember that I should be checking his parathyroid hormone because he does have stage 3 or higher. So I am going to order that today. And confirm that he's got chronic kidney disease, and note that we are assessing for progression or complications because I'm checking a PTH today. Let's save that diagnosis. Ooh, and I'm going to assess through labs. Sorry about that. Nice little reminder when I've forgotten to click something, and really easy to do. I'm also going to look at his diabetes diagnosis just to confirm that he indeed has type 2. And we provide all of the supporting evidence here, which is nice to remind me of all the things that have happened to Todd in the recent past. Everything from the medications that he's been taking to confirm that he's actively being treated, to the fact that he's been diagnosed with neuropathy, some skin ulcer, and that his blood glucose has been elevated in the past. So I can meaningfully say that he's had high blood sugars, that he has peripheral neuropathy, and that he has had skin ulcer with diabetes, and able to confirm this, and note that we are continuing to monitor for complications and make sure that he is doing well in his diabetes care. Under the medication section, what we have is a nice reminder of patients who are on longer-term chronic medications where there's an opportunity to consider giving them a longer-term script, like a 100-day script. And here, for example, for his glimepiride for his diabetes, I am going to go ahead and confirm that 100-day script because it's going to be a lower cost to the patient. And, oops, sorry, I'm confirming yes, and then I'm going to save that task. Under gaps in care, this is where those regular reminders of things that may not come up generally always in a visit where I'm addressing something like their diabetes care, this is where I get those reminders to make sure that some of the things that need to happen actually happen for the member. Here in particular, we've got fall risk screening. So I may be focused on the diabetes, but I may not remember that I should really pause for my senior patient, Todd Black, to really check in and make sure that he has been, whether or not he's been falling or he's been having any difficulty with balance or walking. And so this is just the nudge for us to have the conversation. We have the conversation. I also remember and can encourage him to use that free gym membership. Not quite today in COVID, but hopefully soon, and also see the recommendations and why we talk about this that came directly from the Centers for Disease Control. Under clinical recommendations here, this is where, even though I've been focused a lot on his glucose control and I've done a better job for it, as the recent lab results will show, I haven't been thinking as much about preventing his cardiovascular risk. And so here, Clover has curated very nicely the reminder. Todd's got type 2 diabetes. He also has coronary artery disease here. These are his recent lab test results showing his good glucose control, that he's got normal liver tests, and still that his cholesterol level of LDL at 72 is higher than is optimal for someone in his state. And if I'm not quite sure and I want to see what those guidelines look like, I can click right on it. And even though my internet is slow, hopefully the physician's office is not as slow, and I will go right to the actual article and recommendation that I can see comes from the American Heart Association and is published in their journal. It's kind of nice and handy there. And then, since we want us to start a high-intensity statin, Clover will tell me exactly which statin is on the formulary. This is often a kind of pain for many providers, where I'm going to say I need to put them on a statin, but what was Clover's formulary and which dosage should I use? And it's here right for me, very simple and straightforward, and also reminds me what the dosage level would be for that high intensity statin. And so again, I'm like, this is great. I'm going to prescribe that medication, and this is a great way to kind of get Todd off into a better onto a better foot as he leaves the office. This other piece is Clover just asking me a little bit more about what else might we be concerned with. And here, for example, if Todd were particularly frail, and I would say, I wouldn't be that surprised if you were to die in the next 6 to 12 months, then then Clover tells me that they have a supportive care program that can be offered to Todd. And I think that this is a great idea. And so I am going to let Mr. Black know that Clover is going to call him about these enhanced supportive services, because that's one of the reasons it's so great to have Clover members in my practice, is to be able to access these kinds of services. And so I'm going to finish this. I'm going to sign and save the visit. And that is what a Clover visit looks like. So if I can figure out how to stop sharing my screen, I want to really thank you for taking a few moments to review this with me. And I'm going to hand this off to my colleague, Dr. Spector, who's going to tell you more about what this looks like in managing a panel of patients.
Hey, Sophia, thanks so much for that great demo. Hello, everyone. My name is Dr. Mark Spector, and I'm the Chief Medical Officer at Clover Health. And today we have 3 primary care physicians with us who are longtime users of Clover Assistant, Dr. Shah, Dr. Picciano, and Dr. Schwartz. Welcome, doctors. Would you please introduce yourselves? Dr. Shah, would you mind going first?
Okay, so I'm Dr. Shah. I'm a practicing internist at 1060 Broad Street in Newark. I've been in practice for 40 plus years, which seems like a long time. And I've been with Clover Assistant and Clover, I think, ever since its inception. And I'm extremely happy with Clover, mainly because I feel that our input as doctors is appreciated and welcomed more so than any other insurance company that I've dealt with.
Dr. Schwartz, how about you?
Hello, my name is Dr. Daniel Schwartz. I'm a primary care physician in Philadelphia. I've been in practice for 20 years in a group setting with one other physician, and have been a user of the Clover Assist device for about two years now.
Dr. Picciano, and now you.
My name is Dr. Robert Picciano. I'm a board-certified internist practicing in Newark, New Jersey. I've been in private practice caring for both inpatient and outpatients since 1991. And my practice is primarily that of primary and preventive care.
Next, I think it'd be important for us to find out how these physicians use Clover Assistant in their practice. Dr. Shah, would you like to start, please?
I'm very much a hands-on doctor, so I basically do open up Clover Assistant the minute I have the patient in the room, see the patient, and then I go to the Clover Assistant. And basically, the value of Clover Assistant is it makes me see the patients in a broader light, as opposed to if somebody just comes in for a URI, which is an upper respiratory infection, and I just see the patient for that at that point. If I'm on the Clover Assistant, it'll make me think, did I do my A1Cs? Did I do my PTHs for the CKDs? So it broadens the visit and takes the whole patient in, you look at the whole patient rather than just one thing that the patient came in for.
Dr. Schwartz, what about you?
Sure, thanks, Mark. In recent years, the value-based care model has changed drastically in the primary care world. And in order to embrace that, we've been able to utilize Clover Assist in our practice to transition this type of care seamlessly. It allows us to intuitively add diagnoses and add treatment pathways to the plan of care in a way that improves our outcomes, improves utilization, and decreases morbidity overall.
And last but not the least, Dr. Picciano, how are you using Clover Assistant in your practice?
My typical workflow would be that I would be handed a face sheet on the patient, and I would see that it's the patient is one of the Clover patients. I would usually open up the Clover Assistant prior to going into the examining room, see what pertinent information is being asked of me from Clover regarding the patient's diagnoses, particular questions or concerns, that you might have that have been addressed either by me previously or from other practitioners, and then make sure that those exact issues are addressed when I go in and see the patient.
I think it's important for us to understand what clinical value does Clover System bring to your practice. And if you have specific examples, we would love to hear them. Dr. Picciano, would you please go first?
Probably the biggest value that I've seen, clinical value, is perhaps not when it's a patient that I have been following for a while, but rather some data that I may get from visits that the patient has made with other practitioners. They may have either sought care on their own, or there's claims information that's in there that has generated clinical information or laboratory information that I either have not had the chance to address yet, or the patient has never brought that to my attention. So I do find sometimes that when the patient has seen another physician, particularly a specialist, it will mention that Dr. Smith has diagnosed congestive heart failure or atrial fibrillation or cardiomyopathy. Are you aware? Do you agree? How are you treating it? And admittedly, there are times that I was not aware of a specific diagnosis that the patient had, or a condition or a medication or what have you. And so it's brought to my attention through Clover Assistant, where sometimes I may not have had the dialogue just yet with that particular specialist.
Dr. Shah, how about you?
A lot of patients are all over the place, and so we are not always aware of all the diagnoses that the patients have, because unfortunately we don't always get feedback from the consultants. And so what Clover Assistant does is it tells me that, okay, the patient had so-and-so diagnosis made by whichever doctor, whichever consultant it may have been, or wherever the patient may have gone. And it makes me, I don't always accept the diagnosis because I'm very skeptical about all the diagnoses that I see on Clover Assistant, but I will investigate it. And I'll make sure that, I'm not missing out on something that I need to know about.
And Dr. Schwartz, what clinical value does Clover Assistant bring to your practice?
Yeah, sure, Mark. In the value-based care model, it's so important to close some of these high-level gaps that and measures that we're sort of guided by Clover and other insurance companies as well. And the Clover Assist intuitively can lead you to decision making. And if we look at, say, diabetics, for instance, who may or may not be on a statin, it can help guide us to help close these gaps in patients who may require a high intensity or a low intensity statin, or in general where patients may have normal lipid parameters but are suggested to be on a statin to improve outcomes, and these are things that are difficult to discern from paper charts that you're looking for years, and with so many things going on and so many moving parts, the device helps you and the platform helps you kind of sift some of that information out more intuitively.
Doctors, I'm really curious how Clover Assistant platform compares to other products that you see from other payers. We'd really love to know how we're different, if in any way. So, Dr. Picciano, would love to hear from you first.
Probably the biggest difference for me is how intuitive and how much sense it makes the way Clover Assistant operates compared to the others. And Clover Assistant doing, these individual patient reviews of medications, diagnostic testing, diagnoses, done in real time per visit and updated per visit, makes to me an extreme amount more sense than having someone come into your office, a representative from an insurer, in November or December to tell you that you're missing a whole lot of mammograms, a whole lot of A1Cs, a whole lot of this, a whole lot of that. Some of it, may be just tactical and logistical that the patients didn't come back in or whatever. But when the way that the other companies have tied their financial incentives to those metrics, at the end of the year, if you cannot reach it by a deadline, they're clearly very, very punitive, and I have experienced it firsthand.
Dr. Schwartz, how about you?
With some of the other platforms, we're left with kind of an older school model of digging out information and then making changes based on what we find versus the Clover platform, which intuitively keeps you sort of moving the ball forward by making recommendations that fit with the value-based model.
And Dr. Shah, how is this platform different from other payers' platforms that you are working with?
It is very different because it's at the point of care rather than a year later when I'm being asked by certain insurance companies about verifying certain diagnoses that the patients may have claims for, coded for in the claims. And after the fact, it's extremely difficult to know to verify those diagnoses. And it doesn't help me any, helps the insurance companies, I'm sure, with whatever they have to provide to Medicare. But as a clinician, it doesn't help me any to know that my patient had a diagnosis of a stroke 2 years ago, 2 years after the fact, basically.
Doctors, thank you so much for being with us here today. We really appreciate your time. Is there anything else that you'd like to add before we sign off?
I really appreciate it, and I really appreciate the fact that you come to us for suggestions, which makes us feel like we are part of I feel I'm part of the Clover family for the longest, so that's a good feeling, and I've kicked many an insurance company out of my network, so.
Dr. Shah, you definitely are part of the Clover family. So I just want to also say thank you, all three of you doctors, Dr. Shah, Dr. Picciano, Dr. Schwartz, thank you for taking the time and being with us today.
That was great. Now we'll pass things back over to Joe for financial highlights.
Yeah, thanks, Whitney. I never like following doctors. I feel like the finance people always follow doctors, which I don't like. But anyway, that was great. And so just to kind of level set from a finance standpoint, so I previously walked you through where we are in our direct contracting business. And due to the remaining uncertainties around some of the details of that program and the fact that our first performance year will not begin until the second quarter of next year, we have not yet included detailed projections herein, and those results are obviously not included in our historical financial performance either. And so what we're going to do now is focus the next few minutes on our Medicare Advantage opportunity, kind of our core MA business. And on that topic, as you're aware, we're in the middle of the Medicare annual annual enrollment period. So we can't share many details at this point, but obviously each AEP year is different, and we take that into consideration. This year's AEP is very unique because it contains a presidential election, 2 Georgia runoff senatorial elections, compounded by growing COVID restrictions. We're monitoring our progress in AEP and also remain excited about OEP, as we have a strong record during the OEP period, which follows AEP. Despite the election and the COVID wave, we continue to target an average of over 73,000 Medicare Advantage members during 2021. So before we get into more numbers, I wanted to highlight what really excites us about this opportunity from a financial perspective. And so first, market dynamics. As you've heard, we're in a growing market, and we've been able to capture meaningful market share in established markets via a 50% plus take rate. We think that puts us in a very strong position to continue to drive growth over the following years. Aligned incentives. You heard a lot about this from Vivek, but it's a special opportunity to have our economic alignment tied to that of our members. And lowering cost and improving outcomes will enable us to offer more obvious plans and therefore drive more growth. Third, a predictable revenue stream. With high member retention and consistent payments from CMS, we believe there are some uniquely software-like characteristics in Medicare Advantage. Next, margin enhancement. As Vivek mentioned, and as I'll point out a little bit in more detail later, we've already shown the ability to hit industry margins with our Clover Assistant population with a myriad of potential upside opportunities, including more time for the Clover Assistant to make an impact across a wider scale and improving our STAR scores. Next, strong unit economics. Going back to the software point, we see favorable LTV to CAC economics that we highlighted in our previous deck and expect to continue to enhance this metric with further margin improvement over time. And then lastly, attractive free cash flow generation, because we have limited capital expenditures as we do not scale with brick and mortar, but rather scale via software. So now what I wanted to do is just take a moment to quickly walk you through what our historical P&L looks like structurally. And I know this, this may be review for some that are closer to the healthcare side. But again, just kind of going down the slide, most of our revenue is generated from premiums. We get paid per member per month, predominantly from CMS payments. Our payment on each member varies and is based on demographic and clinical factors. So we generally get paid more for members that are documented to be sicker and need more care. This dynamic leads to one interesting factor to keep in mind, and that's the differential between returning and new members. As we discussed in our original presentation a little over a month ago, new members tend to have worse margin profiles than returning members, in part because of the lack of information about new member disease burden. As a reminder, we provided illustrative figures in our original materials showing a new member MCR range of 95 to 105% and a returning member MCR range of 70 to 85% going forward. Next, we go to investment and other income. This has been less than 1% of revenue, so not a material impact for us at this point in time. On the medical expense side, that's our largest expense on our income statement and runs at over 80% of revenue industry-wide. This includes the cost of care for our members, such as inpatient admissions and ER visits. One thing to mention is we do tend to see some seasonality with typically modestly higher medical expenses in Q1 and Q4 compared to the second and third quarter of the year. We then have other expense items such as operating expenses broken into G&A and salaries and benefits, depreciation and amortization, which again is relatively small, giving minimal capital expenditures, and interest expense. Worth also noting from an income tax perspective that we do have a significant amount of federal net operating loss carryforwards that we anticipate will reduce our tax burden in the near to medium term as we achieve profitability. So now getting into our historical financial results, here we've included a bit of background on our annual historical results. For membership, we exhibited high growth of about 31% between 2018 and 2019. And in particular, we achieved this largely on a same-store basis as we only added 7 counties. And as Vivek mentioned earlier, we've spent most of our growth focused on existing established markets as opposed to new markets. MCR results were relatively in line year over year as we focused on building out the Clover Assistant, which again was a mid-2018 launch, so limited impact in 2019, and we began to scale the platform. In a few minutes, I'll walk through a detailed waterfall of how our MCR over time, so you have a better sense of how we have improved and will continue to improve our margins. In 2019, there was a material improvement in our operating expenses as a percentage of overall revenues as the company took steps to begin a path to profitability. You will also see that other expenses grew significantly in 2019, and that was driven by non-cash accounting impacts relating to convertible securities, warrants, and other related costs. We believe that many of those costs will be eliminated after our transaction closes and we ultimately become a publicly traded company. So now looking a little more recently at the current year 2020, we accelerated our growth to 39% year over year with continued penetration of market share and adding 8 more counties between 2019 and 2020. Due to a strong product offering, we also continued our net growth throughout the year after AEP ended. Moving down to the components of MCR, you'll see some volatility given the current pandemic, but let me just kind of talk a little bit about each quarter. As we noted earlier, and as I'll talk about in a little bit, we view Q1 as a clean quarter that is a good representation of our continuous improvement in our margins, and again, I'll share more detail on a separate slide. As we think about the second quarter of the year, beginning in late March and early April 2020, COVID-19 caused an increase in our inpatient costs as we started to experience admissions caused by the virus. That increase in inpatient costs was ultimately more than fully offset by a reduction in outpatient and office-based utilization during this second quarter. We estimate that the pandemic reduced our medical costs by about 10 to 15% of premiums during this quarter. And now looking at our third quarter results, in which we reported an MCR of 86.7%, that was driven by reduced utilization in the first half of the quarter, but noting that utilization levels in late August and early September were approximately 95% of pre-COVID levels. Again, looking at 2020 as a whole, we do not believe we are an outlier as compared to the rest of the industry. We also continue to build a more efficient operating structure, with run rate OpEx looking relatively flat compared to 2019, despite almost 40% growth in year-over-year membership. Now here I want to briefly address our full year 2020 expectations, understanding that there are uncertainties about how COVID will ultimately impact the fourth quarter, particularly considering the recent resurgence of cases that we're seeing across the country. As an earlier stage company, variations in environmental factors would likely have a more material impact on us than it would on larger MCOs. That being said, we expect average 2020 membership to be between 56,500 and 57,000, with total full year revenues to be between 650 and 670 million. We expect a full year MCR between 83 and 85%, and an adjusted EBITDA margin between -6% and -7%. So just to reiterate, and again, we've talked a lot about Q1, and the reason is because it's the most recent quarter with the impact of Clover Assistant on both revenue and costs. And as Vivek mentioned, and I'll reiterate here, we view the first quarter as a clean quarter because, as you can see in this chart, we had a relatively small net impact from COVID. We saw a roughly equivalent impact from COVID-related admissions and drug spend as we did from the reduction in services, given that our established markets were hit early and hard by the pandemic. We also saw the impact of Part D seasonality and an extra day of medical costs from the leap year, which makes us believe that our actual MCR as reported for this quarter is a good approximation of a run rate in a normal course of business. So now, as we look ahead, this slide gives you a sense of where we project our Medicare Advantage business to be in the near term. So now I do want to note that even though these 2021 projections continue to represent a good estimate, we will be providing our formal 2021 outlook with our year-end earnings report, assuming the transaction closes sometime in the first quarter of next year. There remains a good deal of uncertainty in the areas of COVID-related costs and the ultimate impact to our operations, the evolution of the financial parameters around the direct contracting business, the actual amount of net proceeds from the transaction and targeted investments to drive growth, which are not currently contemplated in this model, and then also results from the enrollment periods in which variability of member adds by region could cause shifts in our revenue and margin profiles. So looking at the projections, we start with average MA membership. In this calculation, we take into account growth from AEP, OEP, as well as the special enrollment period, SEP. We're projecting our 30% growth accelerating over the next few years to over 40%. We think that our software-driven strategy will allow us to capture 30+% growth over the long term, representing roughly 3 times industry averages. We believe the capital we receive from this transaction will enable us to invest in our growth strategy by, among other things, following our growth in direct contracting in certain markets, and that will allow us to drive incremental upside to our midterm projections. We believe we can add millions of eligible addressable lives in 2023 and beyond, and materially accelerate that 40% figure for several years. From an MCR perspective, long-term, we only have about 600 to 700 basis points to get to our longer-term targets. We believe we have line of sight to achieve that through increased Clover Assistant adoption and product enhancements, as well as potential tailwinds from Stars. I'll give you a more detailed bridge of our MCR improvement on the next slide. And then from an operating cost perspective, as you can see in our historicals, we've made strides in reducing our OpEx and expect to continue to get more efficient and benefit from economies of scale as we continue to grow. As we continue to enhance the Clover Assistant, our technology stack takes the place of certain clinical and administrative functions, which allows for increased efficiencies over time. And then from an adjusted EBITDA perspective, we believe that's going to put us in the 6 to 7% range long term, which represents a slight beat to industry, despite margin headwinds that result from better than industry growth. And as you can see, we currently forecast to become positive on an EBITDA margin perspective by the year 2023. And as we think about a KPI going forward and what stats are really going to drive our results, one will certainly be lives powered by Clover Assistant, which on the MA side, as shown here, we measure by a Clover Assistant penetration into our physician markets. And again, just as a reminder, these results here do not include any financial results yet from our direct contracting program. So on this page, we've included this to give you a little more granularity into our line of sight into how we get to and achieve our long-term MCR targets. So as you can see, continuous improvement and expansion of the Clover Assistant not only is critical to our mission to improve every life, but directly ties back to our financials, supporting that economic alignment between our business and our members. What's also interesting is the synergistic relationship between the margin impact we expect to see in direct contracting and the margin impact we expect to see in Medicare Advantage. So I mentioned before that we believe we have upwards of 1,500 basis points of identified opportunities for cost savings in the direct contracting program. To the extent we're able to achieve those savings in direct contracting via the Clover Assistant platform, we'd expect meaningful synergies and commensurate cost savings in our Medicare Advantage business as well. We also believe there'll be some synergistic aspects to Clover Assistant coverage, as we can effectively cross-sell the Clover Assistant opportunity between MA panels and original Medicare panels to make the platform even more attractive to our physicians. So when we look and we see roughly 600 basis points of margin to go with respect to hitting our 2023 year-end target from our Q1 run rate, we have a lot of conviction in hitting that given the cost savings opportunities for the Clover Assistant platform that we've already identified, as well as that cross-selling opportunity. So again, looking long-term, the Clover Assistant will be powering in excess of 250,000 lives in 2021, and we believe in excess of over 600,000 lives in 2022. And we're very excited about this unprecedented growth opportunity for our platform. So with that said, I'll hand it back over to Whitney to help us dive into Q&A.
Great, thank you, Joe. And thanks everyone for being a part of the day, which comprised of our live presentation and pre-recorded demonstration and physician panel. None of the physicians on the panel are employed by Clover or receive payments for taking part. With that, we'll open the call for Q&A. As a reminder, to ask a question, please use the raise the hand feature. We have a large audience in attendance today and questions coming in already, so please limit yourself to one question and one follow-up question, and we will do our best to get to everyone today. If you have additional questions, please feel free to raise your hand again and get back in the question queue. Great, and with that, we'll take our first question from Donald Hooker.
Hello, can you hear me?
We can now, thanks.
Oh, super. Yeah, I was curious about if you could, your perspective on the Medicare direct contracting program, kind of bigger picture. Sounds like an interesting opportunity. Maybe a high-level question. How might this program be changed under a Biden administration since it was initiated, it seems like it was initiated by the CMMI under Trump?
Yeah, I think obviously it's impossible to predict what different administrations are going to do. But generally speaking, programs coming out of CMMI, generally enjoy bipartisan support. We've seen on our end no signals of any change in terms of engagement with folks who are familiar with the Biden administration. We've seen no signals in that either. And then just generally speaking, because direct contracting is actually not related to Medicare Advantage, but is actually focused on driving more value for the government within fee-for-service, we'd be very surprised if the government made negative changes to direct contracting, given it's around helping create sustainability for the fee-for-service program, which generally speaking has bipartisan support, and generally speaking is something that Democrats, generally support, which is expanding fee-for-service, making sure fee-for-service is sustainable, and there's obviously contemplation around lowering the Medicare age to 60. Another question as to the feasibility of that, but again, just general belief. Our belief that the Biden administration is going to be supportive of anything that allows more sustainability for fee-for-service, which direct contracting certainly allows for, given it's a guaranteed savings construct for the government.
Okay, thanks for the question. We'll take our next question for Jalandra Singh at Credit Suisse.
Hi, can you hear me?
Yes.
Okay, on the DCE side, I know Joe mentioned that in terms of operating margin long term. It's still TBD, but can you give some color around what the margin range could look like? How should we think about the scalability there? Does incremental live or incremental physician you add to platform come at a much higher contribution margin? Some flavor around the margin possibility or a long-term range there for that business.
Yeah. I mean, I'll just to not put Joe in the uncomfortable position of stating margins and then us holding him accountable to that because it's a wide audience here. You know, we generally speaking, in terms of external sharing of that information, we obviously have clear internal goals and targets, but because the program is new, we want to be very, very cautious around sharing very specific margin targets for direct contracting. You know, I think we feel pretty comfortable, and Joe, correct me if I'm stating anything incorrect. We feel pretty comfortable about being able to achieve break even for 2021 as it relates to gross margin on direct contracting. We have very high conviction that that the 1,500 basis point gross margin is achievable over a period of time and uniquely achievable for Clover, given the Clover Assistant platform. And so a lot of the initiatives Joe went through are unique to Clover. Those are not initiatives that would be easy for other payers to execute upon without a platform like the Clover Assistant. So we would not say that those margin targets are ones we would think as reasonable for competitors in the space. Now, putting that aside, that is our long-term goal, is to hit the 1,500 basis points long-term. That requires great execution, requires obviously not just the adoption, which we've already locked in, but great engagement and execution on the downstream workflow related to Clover Assistant. So from a personal basis, you know, I want to, you know, get there tomorrow and get there next year. In reality, that's just not how execution works. But the goal is to get there as soon as reasonably possible.
Okay, and then my follow-up is around, you know, you guys mentioned that Clover Assistant platform penetration is around like 64%. What is the pushback from physicians that don't want to use Clover Assistant? And is the mix of that 64-36 same on like members who are using those physicians? Like just give us flavor, like is the same similar mix or is different mix than what you say 64-36?
Yeah, it's a great question. And just and Andrew and Joe, correct me if this is wrong, I think it's 61%. So 61% of our members see a physician on Clover Assistant. So let's break out the 39% because it's a great question. One, we want to make sure there's a good understanding around that. So in the 100%, so you've got 61% seeing a physician on Clover Assistant in the 100%. There is about 15% of members that don't see a primary care physician. And that could be due to various reasons. Generally speaking, it's because they're at the very low end of the acuity curve and may not have any conditions that require even one PCP visit a year. Now, generally speaking, we are always encouraging our members to have at least some sort of annual engagement with the primary care physician. So it's not to say that we're not trying to get them to see a Clover Assistant physician or that we're ignoring that population. So we do, the reason why we show it as 61% of 100% versus 61% of 85% is internally we judge ourselves based upon our entire membership, not just those who are actively seeing the primary care physician. And then in the other 25% or so, a large percentage of those are physicians that have a very small Clover Assistant or Clover member panel, i.e. less than 10 members. And so when we think about an ROI perspective, we've done a very exciting shift in our strategy there, where we're actually going to those physicians when we think about generating more value for them on the value proposition is actually enrolling them in direct contracting as part of the Clover Assistant adoption. So our goals for next year is to drive much higher adoption of the Clover Assistant in what we call the longer tail. So that 25%, which is predominantly made up again of members who are seeing physicians where the Clover panel is less than 10. And so now when we're going, and we're actively doing this, and we're finding our close rate is about 50%. So when we go to physicians not in Clover Assistant that have a very small Clover member panel, our close rate on getting them to agree to direct contracting and adopt Clover Assistant is about a 50% close rate. We hope to increase that over time. We hope to show that in our numbers next year, and then obviously launching in direct contracting for 2022.
All right, great, thank you.
Thanks for the question. And we will go to Ralph Giacobbe next.
Hi, Ralph.
Great. Can you hear me?
Yep, we can hear you.
Just got it. Sorry about that. So I guess first, maybe just if you could help a little bit more on the time frame around the STAR improvement. I know you showed the stat of what it would be at 3.5 and 4 in 2023, but help level set a little bit of the realities of sort of making those improvements and maybe just the backdrop of what that means from a reimbursement perspective.
Yeah, and just I understand sort of high level, and Joe, let me know if it's accurate, but I think practically speaking, obviously the numbers we've shared on the P&L side go to 2023. So practically speaking, we would expect the earliest for our features to be able to drive value to where we'd be able to drive that improvement in STAR rating. Obviously, there's been a lot of barriers to that this year due to COVID. So the earliest for a measurement year would be 2021. So that would mean from a payment year perspective, the earliest we would see a payment year improvement would be 2024.
Yeah, Ralph, that's right. Just kind of echoing what Vivek said, is we have not modeled it into, until 2024 on kind of our longer term models. And then it's just a ramp of 3.5 and then upwards of 4. And then, from a reimbursement standpoint, the way that STARs work in the rebate calculation, there's some moving parts, right? So it's not like you just get it, it's not like you just get $40 added to, $50 added to your top lines. There's some moving parts on benefits, but, we would expect, obviously, when that happens, we expect a slight uptick on the revenue side, for those bonus payments. But then, like Vivek said, at that time, we'll make the decision as to how much we want to reinvest into benefits versus letting fall to the bottom line. But for us, we view it as a 2024 impact from a financial standpoint.
Got it. That's helpful. And then just my follow up, I wanted to go to some of your commentary around the site of service optimization and maybe just help us on how Clover helps with that, because I think you noted inpatient to observation and SNF to home health, and I guess I'm trying to make the connection of how you have that attachment point, if you will, if that's not necessarily in the hands of primary care.
Yeah, I think Mark is on. We can obviously, I think Mark's our chief medical officer and obviously has played a very big role along with Sophia and Kumar on the Clover system, but also a lot of the operational workflow. So Mark, just were you able to get that question?
Yep, absolutely. So yes, there are tremendous opportunities on the inpatient versus observation, as well as steerage to the most appropriate site of service, as well as within the same site of service to more efficient, better quality, lower cost resources. And that can be done through operations, which we already do in our MA Medicare Advantage world. But we are going to be combining both just operations, working with primary care doctors who manage their patients in the hospital, as well as hospitalists, as well as case management within those hospitals, to ensure that the proper clinical decision-making happens, not only from an inpatient versus ob status, but also as we're doing discharge planning, providing the transparency to the managing clinicians around what is the most appropriate site of service from efficiency and cost standpoint. So this is going to be a combination of operations and technology providing that transparency.
Mark, maybe just walk through how for example, as it relates to the Clover Assistant, how the ADT feeds as an example are relevant in terms of notification of the admit, why it's important that the primary care physician gets that signal. And if you can then walk through, as it relates to site of service, for let's say an orthopedic referral, why that's relevant that features in the Clover Assistant for the primary care physician.
Yep. So obviously knowing when the patient hits the door is very important in guiding clinical decision-making. Clover will have significant, if not universal coverage with ADT feeds. Is there anybody here who's not familiar with ADT feeds? It's a ping, it's an electronic ping that occurs anytime the patient hits the emergency department or it gets transferred from the emergency department to an observation setting or an inpatient setting. Clover will be receiving those ADT feeds, and then from then on, we'll actually be able to engage with the providers that are taking care of the patient and making sure that the proper clinical decision making is being considered. So ADT feeds through the technology become a very important part of it. ADT feeds will be surfaced within Clover Assistant, and we are going to be at some point deploying Clover Assistant for inpatients for the hospitalist usage, as well as on the inpatient side for those patients that are managed by the primary care physicians. To address Vivek's question in terms of why is site of service important and what are we doing with specialists, I'll just give you an example, a clinical example. So if somebody needs a hip replacement, what typically happens now is PCP will have their favorite orthopedic surgeon, maybe a couple of orthopedic surgeons will give the patient a card and go, hey, it looks like you're at the point where you're going to need a hip replacement, or you're having a lot of pain in your hip, you may need a hip replacement, so why don't you go see my friend? There's really no transparency in terms of where that orthopedic surgeon operates, or there's no transparency in terms of what type of operation he does. So let's just stick with the hip replacement example. A similar procedure can be done in both the ambulatory surgery center, specifically for hip replacement, as well as inpatient. The general technical costs are 30% lower in the ambulatory surgery center setting than they are in the hospital setting. But let's even go beyond that. There are two ways of doing this particular surgery. One is through the anterior approach, and one is through the posterior approach. The posterior approach is the more common approach. It's the older approach. It's where the actual hip capsule is incised and then sewn up back together, which results in a prolonged rehabilitation stay that's going to be necessary. The average time that somebody gets rehabilitation in a skilled nursing facility after getting surgery like hip replacement through a posterior approach is approximately 14 days. Now, if we know that a surgeon can do the procedure through the anterior approach and surface that to the PCP, not only have the procedure done in the ASC, but the surgeon is capable of performing a surgery in a particular way, the average rehabilitation time is then 3 days. So you can see the difference of 11 days of rehabilitation and the average cost of skilled nursing facility rehabilitation, I believe, is around $600. So you're talking about saving $6,000 every time you have this procedure if the patient gets it done at the preferred specialist's office or in a particular setting. This type of logic and thinking and data analysis is going to be pretty much ubiquitous throughout our understanding of all specialists that we're going to be working with, and empowering primary care physicians with that transparency to let them know who is the most appropriate specialist for that particular patient, for that particular problem at this particular time.
And just, Mark, maybe walk through kind of the complexity of the clinical logic, just high level as to why that personalization is really important within the Clover Assistant for the physician.
Yeah, I mean, look, not all patients are the same, right? So, for example, let's take even the same example of the hip replacement. You might have significant differences in the patient profile that's getting that particular surgery. Some of them may actually be scheduled for a lower cost setting that you may want to schedule in a higher cost setting, because our prediction of readmissions or unscheduled readmissions, our sort of charm score, as well as other factors, are going to make us worry that that particular patient actually requires more intense treatment. So that's where that logic is really, really important. A lot of it's data driven. A lot of it's driven through our machine learning algorithms, and taking in all of our data and then constantly learning with that feedback loop. I think that Andrew and you have talked about that flywheel. The flywheel doesn't only exist in the sort of the whole business model, but what needs to be kind of defined, and not only defined, but what needs to be pointed out is that our platform allows us to learn live. Because every time a provider uses our platform, they're providing clinical feedback, which drives the improvement in our clinical, machine learning, and AI models, which allows us to keep learning how to provide better and better care for our patients. But so that data, that clinical data that Sophia, Kumar, myself, and a team of data scientists are constantly poring over is what's driving a lot of the suggestions within Clover Assistant.
And just Mark, on Ralph's question on post-acute care, I think it's and maybe we're going into too much detail for folks, but I think it's helpful. So please keep doing this. If you can go into details to why is it important, or why does a primary care physician, if they're engaged, have a lot of leverage around post-acute care as to where their patient goes? Because I think sometimes that gets lost in some of the high-level conversations.
Of course. So there's a couple of different ways where that the primary care physician can actually impact where the patient goes for post-acute care. One of them is if they're actually managing the patient in the hospital. Okay, and if they're engaged, they can make the decision whether the patient needs home health or skilled nursing facility care. In the event that the primary care provider is not taking care of that patient in the hospital still cares very much about keeping that primary care physician happy, because they are referring patients into their facility. They're the ones that are telling the patient, if you get sick, this is where I want you to go to. So it behooves the hospital to engage with the primary care physician on discharge planning, because frankly, it's good care. If I'm a doctor, if Dr. Smith and somebody from my office calls the hospital and says, my patient, Mr. Johnson, is admitted to your hospital, I'm calling from Dr. Smith's office. If the patient needs to go to a skilled nursing facility, I want them to go to this particular skilled nursing facility and not that particular skilled nursing facility, which will make a big difference in quality and costs.
And just maybe walk through just, maybe high level or even some of the details to, what we've seen, in our own data as to kind of difference in quality and cost amongst different skilled nursing facilities.
Sure. So I would say that the two things to kind of pay attention to is like the overall quality of like 30-day readmissions. You don't want somebody to go to a skilled nursing facility and then bounce back to the hospital for another acute admission. So we look at things like 30-day readmissions. We look at the efficiency of care, meaning what is the length of stay and how much resources is the patient getting? Are they getting the appropriate resources? And there is great variability, and you can really look at the data and understand this great variability in the quality of particular setting of care. And the differences could be tremendous. For example, there are some skilled nursing facilities that could average 30 days on a length of stay at $600. There are some skilled nursing facilities that can manage the patient for the same problem in 17 days. Bringing that transparency to the primary care doctor, especially somebody who's partnering with us on direct contracting or MA, bringing that transparency makes all the difference in the world.
Thanks, Mark.
Very helpful. Thanks, guys.
Yeah.
Thanks, Ralph. We're going to take our next question from Gary Taylor.
Sorry, can you hear me now?
Yes.
Sorry. Appreciate the time today. It is quite helpful to go deeper each time we have one of these. We appreciate it. My question is for Joe. I want to go back to direct contracting, just make sure I understood something correctly. So when we think about 2022, where you anticipate having 500,000 direct contracting lives at the risk equivalent of basically $1,000 per member per month. So that's $6 billion. But did I understand you saying only about 5% of that, or 300 million, would be GAAP revenue? And is that because you're taking global risk, but you're taking the PCC capitation option? Is that why that full 6 billion wouldn't be GAAP revenue?
Yeah. Joe, as part of this, because I know sometimes it could be confusing on something new, maybe first walk through the practical math, if you don't mind, just for kind of everyone, and then maybe go through just like what we will call the GAAP accounting stuff.
Yeah, I mean, again, the practical math is Gary, you're right in terms of what I would say overall risk from a benchmark perspective. At that roughly 500,000 lives. I mean, again, obviously, and we're accumulating costs, as kind of compared, to that overall benchmark, right? And so ultimately, our shared savings against that benchmark will come back in as revenue, kind of putting aside kind of the day-to-day revenue of what actually kind of comes through the P&L. And so as you think about, as we understand the program now, the total care capitation model, actually, even with that model, you only get paid based on the downstream provider arrangements that you enter into with either primary care physicians or other preferred physicians. And so to the extent that those participants are not directly tied to your network, those costs, the percentage of that benchmark, let's call it 95 or 90%, do not actually come through. We don't get that in cash, nor do we ultimately pay that out from a claims perspective. And so again, that 5% is our estimate for 2021 in terms of what percentage of the benchmark we have tied to specific either participant providers with our primary care partners or preferred relationships with some downstream providers like lab, DME, home health, certain specialists, et cetera. I think that we anticipate that 5% of the overall benchmark will actually increase over time the more and more agreements that we sign with preferred physicians as we get scale in markets, et cetera. And so I wouldn't be tied to that 5% longer term. We ultimately think that's going to increase to 10, 20, even upwards of 30 to 40% over time of the benchmark that we will actually get in cash and then in turn pay out to our physician partners. But that is correct. In terms of the accounting for the first year, as we understand it now, only about 5% of that benchmark we expect to flow through as revenue. We then will have that similar amount on the cost side. And then again, any net savings that we get from a shared savings perspective, that will of course accrue over time, but from a cash perspective, which comes after the fact, that will ultimately come through as revenue. And so the P&L optics essentially are higher margin from a percentage of revenue perspective, but again, ultimately tied back to what percentage of the overall benchmark are we saving ultimately, both sharing with the government as well as keeping a piece for us, and then obviously sharing some of that with docs as well.
And just to kind of put an overlay on that, so we're in the full global risk model. So Gary, to your point, you are 100% accurate. So the 500,000 plus lives that will be under direct contract in 2022, it's all Medicare dollars that we'd be managing and owning the savings on.
Got it. So I think full global risk, TCC capitation option, but revenue recognition is limited by, you're a DCE and the revenue recognition is limited by the downstream DCs that you're actually contracting to pay with through capitation arrangements.
And also the savings that we generate when that
on top of that
reconcile also comes in as revenue.
Right.
Correct.
Yep. And Gary, that's exactly right. And again, others on the provider side may be kind of treating it differently from an accounting standpoint based on their arrangement. Again, we can't speak to certainly how others are doing it, but for us, that's the guidance that we've been given, and that's how we believe that the funds will flow ultimately from CMS.
Got it. My follow-up would just be, I think you alluded to this, but you talked about shared, the shared or the savings that you expect to generate from direct contracting after CMS takes its haircut. I thought you alluded to sharing some of that with physician partners. So I just wanted to understand if that was finalized. I thought, and I may have misunderstood, I thought when we had talked about this before, it'd be sort of the similar, the higher E&M code reimbursement for physicians that were using a Clover Assistant. But did you also allude to that for doctors that participate in this program, that there would be an additional financial incentive in terms of some portion of the shared or the savings being shared with them?
Yes. So our goal is as savings are created, we want to share a meaningful portion back with physicians. It's going to be tied to very specific quality metrics and adherence goals around guidelines and care coordination. But that is our goal. So we do think that's going to just be really, really valuable. Now, as part of all of the lives that we've signed up, we did not put into the pitch that there would be shared savings. So the sale and our 50% plus close rate has been purely tied to Clover taking all the risk, owning all the savings, and tied to kind of the incremental payment model on the fee-for-service side, which, as Joe alluded to, is essentially paid for by our below fee-for-service rate structure that we have with a lot of the downstream ancillary services. So we have a lot of flexibility on the shared savings side in terms of how we contemplate it. So there's going to be a lot of, obviously, analysis done on our end, and we want to be extremely thoughtful around the quality metrics and so forth on how we share savings back and how much and so forth. But kind of the short answer is that is our goal.
It seems like that that would help you create a moat around, the DC program for the day, if and when, the larger MA plans wake up and decide, they want to participate in this, a few years head start with Clover Assistant with some portion of the shared savings. Seems like it'd be the beginning of creating some a sustainable, moat around this business for you. So
that's
as I'm thinking about.
Yeah, that is the goal. I think you summarized it really well. So the goal is not just obviously to make physicians excited about it, and but it's to get obviously engagement and adherence to guidelines that we collectively agree on, but to make it essentially a no-brainer for physicians across the United States to enroll with Clover and the Clover Assistant and DCE. We do firmly believe that we're building a moat, and that structure that you just described will enable us to do that. And just the kind of the unique synergies that we have in terms of MA and fee for service and Clover Assistant driving a larger and larger panel are driving more impact across a larger and larger percentage of a physician's panel, creates just more engagement and more value for that physician from a clinical and financial perspective. And it's definitely not lost on us that as Clover is seen by physicians as playing a very, very big role in not just improving the clinical outcomes for their patients, but having a significant positive impact on their income. There's a self-fulfilling prophecy that comes through that. It's why we've upped our targets on direct contracting to 500,000 plus for 2022, just given the amazing kind of reception we've been getting over the last couple of months on sign up.
Yeah, and Gary, one more point. I mean, to your point on, kind of some of the larger players. I mean, some of the things that we've heard in conversations with docs, and kind of talking about this is, if a doc already has a very high percentage of his membership on both, various lines of business, commercial, Medicaid, Medicare, et cetera, if he's already tied in with, he or she is tied in, with United with a large percentage, for example, the idea of also adding fee for service, it gets somewhat monopolistic with some of the larger players. And so that's what we've heard a lot from docs is that, they're not all kind of ready to, to give over 50% or 60% of their entire patient panel across multiple lines of business tied to one payer.
And just in terms of even kind of the point Joe's making about United, it's actually not a bad business decision if, organizations like Optum wanted to actually partner with Clover. So those aren't things that we're opposed to, because practices, as you point out, Gary, do benefit as well. And so, our goal isn't to create a narrow market. We believe all of Medicare is our TAM, MA plus fee for service. So for us, when we think about any arrangement, it's got to be win-win for Clover, consumer, and physicians in the government.
Got it. Thanks.
Thanks, Gary. We'll take our next question from Jed Kelly.
Sorry about that. Hey, can you hear me now?
We can.
Sorry. Hey, thanks for doing this. This is great. Looking forward to seeing you guys in a little bit. As you in any new business, any new technology, as you're building it out, can you just talk about how you're thinking about customer acquisition, the investment in customer acquisition, and your ability to sort of leverage, to get more people on your network?
Yeah. So, I mean, I just think, high level, what is, and obviously we've talked a lot about direct contracting today, mainly because we know there's not a lot of thorough information out there currently. So hopefully this was a helpful kind of deep dive and overview in some of those areas. So one of the main reasons, or one of the reasons, there's a bunch of reasons. One of the core reasons we're very excited about direct contracting, it essentially allows us to bring physicians and covered lives onto the Clover System platform and into Clover's orbit at essentially zero CAC. When we enroll a physician into direct contracting and onboard them onto the Clover System, because the majority of the lives end up coming into direct contracting via claims alignment, it's essentially a B2B type sale. So the moment a physician formally signs with us, those lives, as part of the measurement year, roll onto Clover at essentially zero CAC. And so if you take the 200,000 lives in 21, the 500,000 plus lives in 22, those are thousands and thousands and thousands of net new physicians that are coming onto the Clover Assistant platform, and 200,000 and 500,000 plus lives coming into Clover's orbit as formally covered lives at essentially zero CAC. And then behind that, and as part of that, Joe referenced, we build preferred networks. So we do actually have already arrangements that not just cover local and regional, but in some cases national already. For example, lab and DME that apply not just to direct contracting, but also to MA. And so as we're building those preferred networks, we're incorporating into that MA agreements as well, MA network agreements that apply when we eventually roll out an MA plan in those markets. And so if we look at on the flip side, if we acquire 200,000 and 500,000 plus lives in MA, that could easily be up to $200 million and $500 million on CAC costs in MA. And so now kind of going back to starting with direct contracting, obviously consumers are enrolled with us in direct contracting because of their physician. But Clover is going to be very, very focused on bragging to our physicians' patients as to all the value Clover is bringing to their primary care physician. So our goal in that market is to very much brag and shout from the treetops directly to primary care physicians' patients as to here's all the clinical value that we are bringing to you on a daily, weekly, monthly, annual basis that your physician normally would not have had access to. So we're helping the physician market him or herself and continue to increase their retention. And importantly, we're building a brand at essentially zero cost in the community's eyes, not around an MA plan, not around insurance, but really around clinical value that Clover is bringing. And again, at zero cost, we're doing that. We're not obviously marketing an MA plan, we're marketing Clover's technology. Again, we're going to do it in a way that is, very digestible for the average consumer. So when we eventually trail behind that with an MA plan, we think there'll be some net benefit from that on lower CAC because of the brand recognition beyond just being an MA plan, but actually having driven real value in that community.
Great. That's helpful. And then just following up on with working with the physicians, and I don't know if you covered this, if I might have missed it, but what's the physician's ROI using Clover relative to other demand generation sources?
ROI meaning just from an income
return on investment.
So we don't charge, and just tell me if I'm not answering your question directly, just maybe I misunderstood. But we do not charge physicians to use Clover Assistant, so it's a free platform for them. For example, in MA, in Medicare Advantage, they get approximately 2 times the traditional Medicare reimbursement to utilize Clover Assistant. Obviously, that compensates them for using an additional platform and the incremental time that's required to use the Clover Assistant. In direct contracting, it's less than that. It's about works out to about $45 or so incremental, which is about a third of the traditional Medicare reimbursement, with the contemplation for some future shared savings based upon quality metrics.
Yeah, and just quickly, just jumping in on that as well. If you look at it from a software perspective, it's an interesting model. Like Vivek says, we don't charge for it. I come from an enterprise software background. Normally you charge for your software. But if you think about it, that's an interesting way as we go into the sales cycle and we work with these physicians, we go in and contract with them and basically say, hey, we want to give you software. And normally when they're being sold software, it's because they're going at risk. right? They're going to be taking medical risk from the payer, and they need software to help them with that. Instead, we don't move that risk. You heard in the physician panel, like doctors refer to that anxiety they have, right? They're like, they'll be punished. They're going to be like, there's going to be something hanging over them. They don't have that with the Clover Assistant. We give them software. They focus on care. Clover owns all the risk. We pay them fairly and a boosted payment for primary care, which is fair for primary care because they're underpaid. So they're happy on the payment side. And now all of those interests are aligned. So we come in, give them the software, they use it, they're happy with that, and we pay them more on a fixed basis in order, and they already know that their ROI upfront. There's no variability, like if you hit this benchmark or if you don't close these gaps, we're not going to pay you. You heard about all those things from the doctors. None of that exists. They know they're going to get paid fairly.
Thank you. Helpful.
Great, thanks, Jed. Our next question comes from Richard Close.
Yeah, can you hear me?
Yes.
Great, thanks. Thanks for the time and the question. Just maybe to hit on the penetration rate and Clover Assistant. So what's the process of going back, I guess, in maybe your more core markets in terms of the interaction with the physicians that are not utilizing the platform? What are those discussions, and is there any type of conversion rate that you can talk about people that are not using it and then they end up switching over?
Yeah, so for physicians where, and Andrew and Joe, just correct me if I have some of these stats wrong, for physicians that have 10 or more Clover members, we're at about a 90+% conversion rate. If they're not on Clover Assistant, converting them onto Clover Assistant. Even physicians that are not on Clover Assistant that have less than 10 Clover members, we're still at about a 50% close rate on getting them to agree to use the Clover Assistant. But from an ROI perspective, we've expanded that strategy to tie in direct contracting, just because we think it just dramatically increases the ROI of the conversation in general, and it's a lot more compelling for the physician. We found that it increases not just the close rate, but importantly pulls forward adoption, given that there's just more value for both sides.
Okay, and then on direct contracting, really quick, I was wondering, you mentioned 8 states that you don't have MA plans in currently, where you're seeing direct contracting lives. What are your thoughts in terms of I guess growing the number of counties you offer MA plans, and will you be following sort of backfilling into where you have direct contracting, or does that alter where you offer new MA plans in the future?
No, absolutely. So our goal is to rapidly expand direct contracting and expand to all states and territories. That is our goal with direct contracting. And then from a synergy perspective, we want to follow behind that with MA plans in all states, all territories. And so when we think about use of proceeds, use of capital, what we're gearing for is a rapid expansion beginning for plan year 2023 and then beyond. That allows us to start intelligently deploying the build of the MA networks and so forth early next year. But as you can see in the numbers, our direct contracting efforts are well underway. And that's going to create that foundation with which for us to trail with MA plans behind that. But the goal is to, as fast as reasonably possible while maintaining performance, it is to get nationwide across all states and territories in every county in the United States.
Yeah, and
okay, thank you.
Just Richard, thanks for the question. Just a quick clarification. It is 8 total states for direct contracting for next year. 3 of those 8, we do not have an MA plan, just to be clear.
Oh, okay, thank you.
Great, thanks, Richard. We'll take our next question from Ed Yerma.
Hey guys, thanks very much for taking the question, for all the presentation today. It was really interesting with the physicians. I'm just trying to understand, how do you kind of share best practices among the physician community with the Clover Assistant platform? And I guess, if for those that you see the strongest utilization of the platform, are there any things that you can do to kind of bring to the rest of the physician base to enhance their utilization? Thank you.
No, it's a great question. So, one of the exciting things about direct contracting, just given the enablement of an expanded panel being covered for physicians participating, the really neat thing is it's a common data platform. So the thousands of physicians on it, and as more join as relates to direct contracting, everyone has familiarity with the same platform. So when we think about the opportunities for us to share best practice, there's motivation now for physicians to share that amongst each other. So, we're not prepared to kind of share publicly what some of those plans are, but we have some really unique approaches that we'll share publicly probably next year that will build that moat around improving performance and how physicians are able to help other physicians improve performance. We're obviously not going to be sharing that due to strategic reasons, but it's something that we think will be unique to Clover.
Yeah, I just want to add to that, because I think this is something where we can bring techniques that we see from the SaaS world into the world of healthcare, which, I wish it was already there. But we have, while we're not announcing exactly what we're doing, we do have user researchers in the field. They spend time with the physicians. They gather qual and quant research. We have data in the actual application, because it's real time, right, to measure engagement with every single feature. So we have a lot of data that way we can use appropriate sort of like modern techniques to drive up and maintain high engagement. And we'll be excited to talk more about that stuff.
Great. Thanks so much, guys.
Thanks, Ed. Our next question will come from Steve Tanal.
Can you guys hear me okay?
Yes.
Yes. Awesome. Thanks for doing this today. It's super helpful. I guess I wanted to go back to one of the more foundational points on the MA side. Vivek, I know we've talked about this in the past, but so I'm not totally comfortable. I guess, how does Clover ensure PPO-like access with HMO-like costs? Like, what are you guys doing differently vis-a-vis provider contracts and networks versus other MAOs, and why can't they do the same thing at any point?
Yeah, so if we think about, and this may be more than happy to do a multi-hour conversation with you, Steve, and have our clinical team there, because you've asked the most important question. It's what we built internally. So more than happy to do a deep dive with you on this, or anyone who wants to go into more detail. So I'll do my best to summarize it somewhat quickly so we can also go through other questions. So if we think about the construct of some of the statistics we went through, right? So number one, I referenced the 0.81, so almost an incremental one net new diagnosis surfaced and confirmed by physicians on the Clover Assistant. So if we think about what that does, it gives us a moat relative to all incumbents on capturing conditions earlier, real time. But as part of that is an associated treatment plan that we're also aware of real time and can help coordinate that care. So if you look at the MedX reduction that we referenced of the 11%, 4% of that, or I'm sorry, 11% gross margin differential, 4% of that is MedX related. That is unique to Clover and uniquely driven by the Clover Assistant. And there's that clear line in the data on how we've gotten there, from disease capture, earlier condition capture, earlier treatment planning, and then leading to that MedX reduction. And then separate, we referenced home-based primary care. And so if you think about, again, the incumbents, when they partner with providers such as Oak Street, such as ChenMed, such as Iora, they give up half of all of the economics. And so when they do those partnership arrangements, they're giving up half of the economics. And generally speaking, they're focused on those who generally are able to go to facilities that are brick and mortar based. And we have to also focus on who are the individuals not engaged in those models. So those who are not engaged are sometimes those who are homebound. There's also a lot of friction in the marketplace because existing primary care physicians also create a lot of pushback when they feel their patients are being stolen by a competitor primary care clinic. And then beyond that, there's a huge percentage of individuals at any given time, 3 to 5%, that are of rising risk. So they're not yet in the highest risk pool from an historical claims basis, but where our algorithms show they will be there. And so generally there's lots of arguments between payers and those home-based primary care, or those fixed asset-based primary care models around enrolling them, because it's not easy for a vendor and a payer to agree on how to determine shared savings when it's shared savings off of predicted cost. And so when we describe the 1,900 gross margin basis point differential on our home-based primary care population, we own 100% of the unit economics. We also are able to enroll a higher percentage of individuals eligible and enroll individuals who are of rising risk. So just from a math equation, we have an advantage there, and that's unique to Clover. And then the Clover Assistant MedX reduction I've described again as a math advantage we have versus the competition. And then when you're in a PPO or HMO, that doesn't prevent you from leveraging traditional tactics such as such as payment integrity, prepayment and postpayment review. So there's nothing unique in an HMO versus a PPO that prevents Clover from leveraging what works for other plans. And separately, there's no traditional rate arbitrage. So when someone goes out of network to, let's say, an emergency room, the fee schedule in terms of how that health system or provider is paid is at the Medicare rate. So there's not some sort of rate arbitrage that an HMO has by keeping individuals in network. And then if we go through what Mark described on some of the features that we're rolling out around care coordination, that essentially allows us to create a preferred network of specialists without having to use restrictions or gating that plans typically have to do on the HMO side. And so we can still get the benefit of care coordination to specific specialists without creating the restrictions and the gateway there. But there's other components within that. And I see Kumar popped up on video, so let Kumar go through a little bit more on the home-based primary care side. That's what Kumar leads as one of his many projects.
Thanks, Vivek. Hi, everyone. My name is Kumar Dharmarajan. I'm a practicing geriatrician. I'm also a cardiologist, and I oversee essentially clinical services at Clover for our Medicare Advantage members, as well as on the direct contracting side. And one of the programs Vivek referred to is our in-home primary care program, where we essentially target our sickest members who are frail, they have multiple chronic conditions, they have advanced illness. And I think a key point to extend what Vivek is saying is we try to do it all in a proactive way. I think while many health plans are reactively addressing or trying to address members who they feel are poorly managed, we do things in a proactive way in a few ways. So one, we have algorithms running on the background that literally every day are identifying members who are not just currently expensive and predicted to continue to be expensive with poor health outcomes, but those who we think will be expensive through poor health outcomes in the future. And not just in a generic way, but expensive and poor in a way that we believe we can move the needle on, right? Because there's some people who are expensive, like, Mark gave the orthopedic surgery example. There could be a healthy person who just has an elective hip. They're expensive in year one, elective hip replacement, to be clear, but they're not going to be expensive year on year, and that's not the right population to target. And the thing we do is, in addition to being proactive, we literally leverage our platform and the feedback and the signals we get from doctors. So as many people know on this call, health plans traffic in administrative claims data, right? That's billing data. It's not clinical data generally. And the problem with billing data is that it's lagged. It can take 90 days for that bill to come in. So it's not a good sensor for someone who needs help right away. And it's really coarse data. It was never meant for risk stratification purposes to identify the sickest members. yet that's what health plans do because that's the data they're limited to. But through Clover Assistant, we literally get updated real clinical data on our members. One of the examples Sophia showed on her demo was patient prognosis. So we know, and this is the data, doctors are really good at identifying their patients who are sick. And they're really good at identifying patients who might pass away in the next 6 to 12 months. And we know, and I'm sure a ton of people on this call know, the last 6 months of life are littered with poor health outcomes. They're very expensive generally. A lot of people end up dying in hospitals even though they never wanted to be there. And so we literally ask doctors, would you be surprised if your patient were to die? And they tell us sometimes, no, I wouldn't be surprised. And then we intervene right away. And so we get that signal. We leverage the doctor-patient relationship and the trust that's there, align with the programs the health plan offers, and immediately are able to engage patients. And I would say the last thing to underscore, people have been talking a lot about moats here. In general, for care management programs, health plans can sometimes only get 20, 30, 40% max of its target membership in these programs. Our in-home primary care program, I looked at the data this morning, we're at 67%, right, of our target population. So we're literally 2x. And we have a team of folks on the inside who are specialized in talking to older adults and talking to them about really free benefits that we offer to them that we believe can improve their lives, improve their health, and improve their health outcomes and lower MedX. And so really, I think the moat here is it's a combination of data, analytics, platforms, visibility into doctors, exceptional engagement, and then on the back end, having an exceptional program that when you have it all going together, it's actually very hard to replicate.
Thanks, Kumar. And I'm just going to kind of prompt you with one more question, but just that stat that Kumar described, 67%, that is vital for anyone interested in understanding Clover better to understand why that's so important. So if you talk to incumbents are very far off from anywhere close to 67% engagement of the eligible population for comprehensive primary care. And so when you look at P&Ls of primary care vendors, they only reflect those who actually enroll. They don't reflect the members that are within plans that never enroll. So that is a vital statistic. So when we display the gross margin differential that we're able to drive with home-based primary care, it's across the entire 67%, not a tinier percentage that you would see in other plans. I think, Kumar, if you can just go through why do we believe that home-based primary care as the first approach is the right approach for the most acute population, and why brick and mortar primary care, while good, is not ideal relative to home-based primary care for that population?
Yeah, I think that's really easy. I'm going to take a step back. The health system was not designed to care for frail older adults, right? So if you think about brick and mortar visits, it's 10 to 15 minutes with the physician. And sometimes these frail older adults
on that, Kumar, compare it to not the 10 to 15 minutes part, but when we think about an option of brick and mortar intense primary care, some of the newer primary care models versus home-based primary care, we can comp those two.
Yeah. And so, and the newer models, I mean, Vivek is probably referring to some like the Oak Streets, the ChenMeds, the Ioras. As he said, they do a good job at what they do, but the reality is they don't access many of the patients who need to be accessed. There are a ton of frail older adults who literally, you don't see them walking in the street because they live on the third floor of the walk-up and they never get out unless they get sick and are unfortunately carried out by EMS. And so you actually need a model that meets patients where they are, both to even get them hooked into care, right, which is a critical first step. But then when you go into the home, you learn a ton of stuff, right? You get to see all the medicines they're taking. This is a true story. One of the doctors in our practice, our in-home primary care practice that we operate, visited a couple with dementia, meaning they had bad memory, right? And they literally had 38 extra bottles of medicine that they were giving each other. And both of the couple had dementia and didn't have good memory. So there were 6 extra bottles of antibiotics. There were 6 or 7 extra insulin preparations. So for folks who know insulin, if you give yourself the wrong amount, the wrong type, your blood sugar can tank and you can end up on the floor and you can even die, right? So you see these sort of things in the home that you do not see in the office, and we routinely see that. Plus, when you go to the home, they're caregivers there. And from a social determinants of health perspective, you understand how they're living, you understand their challenges. And I think that's a key part of our approach, which is treating the patient holistically. So addressing the medical conditions, but addressing the social resources that are really important they're a prerequisite for improving medical care. If you don't help someone with their housing, you're not going to help them with their diabetes. And not only is that you learn more, can you intervene deeper? It's much more scalable, right? So, a small number of teams is essentially able to cover a state in New Jersey. We essentially have 10 doctors who can cover the whole state of New Jersey because they're able to be strategically located in different population pockets. And you would never have that with brick and mortar. So we access better, it's more scalable, it's cheaper on a per patient basis because you don't have to build brick and mortar, and it's more effective.
And Cooper, maybe just walk through as well why, when the existing primary care physician wants to get involved, why it's important as part of a business model not to formally steal patients from existing primary care physicians, but really, obviously play a very comprehensive role in home-based primary care, but partner within the ecosystem versus stealing patients.
Yep. Existing primary care physicians have relationships with their patients, and many of those relationships have been many years in the making, and they know important things and they have important influence. But existing primary care physicians can't spend 60 minutes with a patient. They don't have social workers and pharmacists in their office. They're not often available 24/7. So we want patients to maintain their ties with the people they trust, but we want to serve as an important extender because we see things in the homes and we have resources that regular physicians don't. And we think when we work together, patients benefit the most. Now, some physicians may no longer be able to see some of these patients. They're homebound. They literally can't get out of their home. We're happy to take over full-on care. But I think the key philosophical approach here is whether we're the only physician taking care of these patients or we're collaborating with another PCP, I think an important philosophical standard we hold ourselves to is we still take 100% accountability for care and outcomes, even if we're managing with someone else, because we think that's the only approach one could take to be 100% patient-centered and get to the outcomes we like. So, it's important to collaborate, but it's also important to have that full accountability at the same time and to feel it.
And Steve, there's a lot of aspects we can obviously go into much more detail and gory detail, and happy to do that offline with you or kind of anyone who wants to understand the answer to that question, because it's a great question.
Yeah, thank you guys very much, and I apologize for the background noise here. Hopefully you can still hear me good. That was super helpful, and I will take you up on that, Vivek. I'd love to go through it a little bit more, but maybe just as one follow-up, one other thing that I noted to come back on was something Joe said around the example on a 29% gross margin on DCE, or direct contracting, really. I don't know that I followed that math exactly, so maybe Joe, if you could just walk us back through that example, that'd be great, and that's all for me. Thanks.
Yeah, sure, Steve, happy to do that. And again, that's where kind of the complexity comes in of the revenue piece on the P&L versus the overall benchmark. I would say, again, the best way to think about it is, the easiest way to think about it is our savings opportunity on direct contracting. It is against the overall benchmark, right? So even kind of ignore the accounting, piece of it. Again, as we think about kind of the $1,000 PMPM benchmark, we're measuring ultimately our savings against that benchmark. So whether we save 1, 2, 5, 10, up to 15, 1,500 basis points or 15% off that benchmark, that's really how we're going to, think about that from a funds flow perspective, think about that from a savings perspective. That's how we're going to kind of communicate with docs. It's really going to be the percentage of savings against that benchmark. Where the complexity comes in is where you have only a piece of that benchmark being recorded as revenue. And so in my example, in year one, we estimate that only 5% of that benchmark will actually flow through our P&L as revenue, and then ultimately as medical costs, right? All the other costs, all that kind of 95% or 90% of the rest of those costs are going to be kind of accumulated in a pool outside of the P&L. And then we're going to track savings against that kind of outside of our true accounting P&L. And so in that example, let's say for 2021, just to make it very simple, let's say in that pool outside our P&L, let's say that we save 4% against benchmark. Let's say that, at the end of the day, CMS pulls everything together and we save 4% of the benchmark, or say $40, PMPM, or $40 for that one member. We would then remit 2% of that back to the government as part of the guarantee. So then what we're left with is $20, which is, say, we're left with 2% of the benchmark, that we've saved. That $20 then becomes additional revenue for us, and we'll estimate it throughout the course of the year, on top of the $50 that's already there in revenue and $50 that's already there in costs. Again, all that's already part of the benchmark. That's just the piece that flows through the P&L. So then what you're left with ultimately is you're left with a bottom line impact of roughly $20 against $70 in total revenue, which again, from a P&L accounting perspective, ends up being a high gross margin percentage, close to 30% margins. The reality is that $20 is still 2% off of the initial benchmark. And so that's where some of the complexities come in. And again, happy to kind of walk you through examples of that offline as well, because it's not intuitive to do in a 5-minute conversation over the phone. But that's why from a P&L perspective, margins may look different. But again, the way to think about it is, let's measure savings as a percent of benchmark.
That's perfect. I think what I missed was the 4% savings in the example. So I'm good. Thank you guys very much.
Great.
Thanks, Steve. Our next question comes from Kevin Fishbeck.
Okay. Hello, can you hear me now?
Yes.
Okay, great. So Clover Assistant seems to be a big driver to the story, how you're thinking about margins, the ability to drive savings, improve benefits, and then drive membership. But I guess in the example you gave about market share over time, you got to 20% market share in the market before 2018, I guess before Clover Assistant actually was kind of fully launched out. Can you just talk a little bit about how you were able to do that? And how you think about other dynamics that can help you drive market share, kind of outside of Clover Assistant?
Yeah, so the way to think about the Clover Assistant in and of itself isn't what is marketed to consumers. Now, generally speaking, we have, exciting things that we think we can do over time that will drive value from a technology perspective directly to consumers beyond even what we're doing on home-based primary care. So the historical growth in our markets has been driven by the plan design attractiveness. So from a perspective of low copays, max supplemental benefits, again, relative to the competition, and then wide physician choice. So, the reason I'd referenced in my presentation, PPOs or HMOs masquerading as PPOs, even when you look at PPO plans in a lot of markets, when you look at the cost sharing for primary care and specialists, it's much, much higher relative to in-network. So yes, it's a PPO plan from a technical perspective, but it's still pretty punitive to go out of network. And so in Clover's markets, our established markets, we have the lowest copays, most sup benefits, and then also not just widest choice, but the out-of-network cost sharing for primary care and specialists is equivalent to what it is in network. And so that combined is what has driven a lot of the attractiveness and growth. The Clover Assistant is what allows those plans to be economically affordable. So to Steve's question is, well, how is Clover doing this? How is Clover actually able to afford this? Because if everyone could afford what we're doing, all the incumbents would literally copy the plan design and copy the out-of-network and in-network equivalency. So that can only be afforded if we're able to do that from an economic perspective. So the Clover Assistant is what enables those plans to be affordable. Now, we obviously took a big risk as an organization, betting that we could drive that unit economics moat relative to the competition, because we wanted to first launch attractive plans from a benefit and access perspective. So that's what drove the growth. And then we trusted ourselves, and maybe, somewhat on a delusional basis, and it's turned into reality now, where Clover Assistant would then drive the gross margin advantage for those plan designs to be economically affordable for Clover, which now they are. And then in terms of the market share question, going back to some of the comments I made earlier, we are very excited to now leverage direct contracting to accelerate deployment of the Clover Assistant. So what direct contracting allows us to do, so Andrew referenced 3 of the 8 states that we're launching direct contracting in, we do not have an MA plan. And so the Clover's presence, and that's going to expand to hopefully many more states beyond that. So those 3 states, Clover Assistant is really what's being deployed. And then the covered lives are in direct contracting, not in MA. So when we think about brand awareness, it's going to be built around Clover's role that we're playing in terms of helping physicians make better decisions. And we're going to be creating a brand with consumers because we think it's a smart thing to do as to how we're helping them with their physician in terms of the role Clover's technology is playing. So then when we trail behind that with an MA plan, we've already now created mass deployment of the Clover Assistant in those markets in advance. We think that's going to have a non-zero positive value on lowering CAC, on accelerating enrollment in MA. Plus, we've already hopefully would have built a profitable business on direct contracting, and all MA is just providing another option for consumers to participate with Clover.
Okay, so just to make sure I understand that, you're saying basically you created a benefit structure that you felt like you could sustainably achieve, but you created that benefit structure in advance of actually achieving it. And this is now kind of allowing you to execute on the reality of those savings to make it financially sustainable going forward.
That's 100% correct.
Okay, and then I guess just the other question, you talked about when you were sizing the market for you excluded the D-SNPs. Is there any reason why D-SNPs wouldn't be a very logical market for you over time? Is there anything about the model that makes it less applicable to that population, or I guess I'd actually think maybe more applicable over time? But any thoughts there?
No, it's a great question. We 100% believe our model can be very, very effective in a D-SNP model. And in fact, if we think about a lot of the individuals in Clover that participate via home-based primary care, we think a good amount of those individuals could, and I don't want to speak for you, Kumar, correct me if I'm saying anything incorrect, would qualify for a D-SNP, but then they wouldn't get access to home-based primary care. And so some of those individuals remain with Clover because of that access to care that we're able to provide. The reason in markets such as New Jersey that we have not launched a D-SNP is some states, not all states, but some states have rules that if you're a D-SNP, you also are required by state law to have a standalone Medicaid plan. And we, at this moment in time, don't view that as the right market for us to get into.
All right, great, thanks.
Okay, we're just about at the bottom of the hour here. We're able to take a couple more questions, but I also want to be respectful of people's time. So please feel free to send us an email if you can't stick around but still have questions, but we will take a couple more here. So our next question will go to Jeff Garrow.
Yeah, thanks for the time today, and thanks for taking questions. I want to ask about patient engagement. You mentioned the 15% of members that don't have a primary care provider. So curious what you're doing for outreach to them. And then I'll just add in the second part, which is from a technology perspective, how does Clover Assistant enable patient engagement outside the point of care for providers, for with those that are members that have a provider relationship?
Yeah, so on the 15% that don't have a primary care physician, or where we don't have data on them seeing a primary care physician. So for us, it's traditional methods in general in terms of initially getting telephonic engagement, and then being able to at least try to visit them in their home with one of our nurse practitioners or partner nurse practitioners, really with the goal of creating an assessment, trying to help engage them with the primary care physician. Generally speaking, there is a significant portion of the 15% that just views themselves as healthy and not in need of frequent PCP care or even once-a-year PCP care. So we're not obviously trying to force people to do that, but we do want to make sure we're able to assess those individuals to the extent that we can start developing signal and being their partner. And so it's a great opportunity for us to learn about someone. There's long-term ROI in us doing that, and obviously it creates kind of natural retention around that. I think if I understood your second question properly in terms of how is it how we're engaging or how we're enabling physicians to engage with their Clover members better? I just want to make sure.
Yeah, and then using technology to do so and thinking outside the point of care. So things like medication adherence, readmission prevention, that type of thing.
Yeah, so there's a lot of interesting stuff that we're doing in this area to basically make care as accessible as possible. It's not due to COVID, but we also accelerated a lot of it due to COVID. So there's the standard televideo, obviously, which we said we built that into Clover Assistant. And the way that we think about this is for seniors, they really want to talk to their doctor, not a doctor, right? So the teledoc model is more about, hey, we need a doctor, let me talk to one. They need to talk to their doctor. So we make it as easy as possible for them to use their phones or whatever, tablets, PCs, to connect to their doctor through Clover Assistant. That's one dimension. Another dimension is that we actually make it even easier for folks who don't have familiarity with technology to actually have a video visit, for example. So we actually will bring a connected device in a safe way to their home if they don't have connectivity, so that they can have a safe distant televideo visit on the same technology platform, but we're actually giving them an endpoint in that case to have a one-time visit if they need to do a check-in with their doctor. So a very simple adjustment, same tech platform, but by adjusting how we actually think about connectivity and actual endpoints in the home, we are able to provide that endpoint now, and then you can now jump into Clover Assistant from the member perspective and engage. And you'll see us do more and more. I mean, if you look at my background, I come from a mobile and IoT background. You'll see us do more and more here to make sure that we cover the member side of connectivity and endpoints to plug into the Clover Assistant platform and provide direct reminders to them, direct engagement with them, and really importantly, direct face-to-face capability to speak to their care team, because as a senior, that's what they really want. So a couple of examples and then more to cut stuff that we'll announce going forward.
And just to add to that, because it's a great question. So Clover Assistant is not just reactive when a member sees a physician, but the data is continuous. So we will also perform outreach to physicians to prompt them to have a member come in and visit them. So it's not just for when the member sees the physician whenever it's kind of part of the normal recurring visit, but it's also identifying physicians and their office staff when they need to bring in a patient and why as well. So that's also part of how we think about our role and our job. And again, that's obviously driven off of our platform. I see Sophia popped up. I think you might want to add something.
Sure. I think, one of the things that we started with was really trying to solve one of the more difficult problems, which is really making sure that our technology was reinforcing the PCP and member relationship. There are a lot of existing other applications, et cetera, and we are building some, and we're also looking at partnering with others, which are good at doing the direct to consumer engagement. And so in the end, the way we're trying to build our platform is that we really start to create that full circle between us, Clover, having the insights and being able to support those better evidence-based care and outcomes, and not only engaging the primary care physician, but increasingly the patient themselves in reinforcing adherence to those recommendations, ways of increasing the ability to do not only synchronous via video visits, but also asynchronous communication. Those are all things that are out there. They're not super hard problems to solve. The hardest problem to solve has been to close that loop back to the PCP so that literally the patient and the physician are on the same page. And that is where we think that and believe we're really going to get that marked improvement in outcomes.
Maybe Kumar might be helpful. Maybe just thanks, Fia. That's awesome. And maybe walk through an example on just on a readmission visit and how that links back into the Clover system for the primary care physician as well.
Yeah, so I think one of the things we do, getting back to sort of proactive, is, we have data feeds on our members on the Medicare Advantage side. This will be available on the DCE side as well, where we understand in real time if they're receiving care in a hospital, whether it's ER, hospital stay, or whether they've gone to a skilled nursing facility after hospitalization. Our goal there, as Sophia said, is to engage the member, provide the care that's needed, and also need to close that loop with the primary care provider. And so if someone is not seeing their primary care provider, that was brought up earlier, what we'll do is use the data and the platform more generally to engage with the member. And then through that interaction, make sure they go to see their primary care provider afterwards, right? So we believe we have a role to play here in that linkage between a member or a patient and their PCP, even if they're not planning on doing it, or even if they are, to do it sooner. Because we know, for the specific example Vivek alluded to, if someone gets discharged from a hospital, we want them to be seen as quickly as possible by their usual sources of care. And we know that that doesn't natively happen all the time. The usual sources of care, in many cases, they don't even know that their patients have been hospitalized. And so our job there is that linkage part that Sophia was referring to, where there's a role for our team, the PCP, and Clover more generally through the data to tie the pieces together. We do that all the time now.
Thanks, Cooper.
Great. Our next question will come from Stephen Helper.
Great. Can you hear me?
Yes.
Yeah. Hey, so we spent a lot of time talking about Clover Assistant at the front end, but I was just curious, on the back end in terms of all the data analytics and the administration of, quote, the health plan. Is that something that Clover developed internally, or do you use third-party pieces along the way?
Yeah, I think as part of that, it'd also be helpful, for us and Andrew specifically, to kind of give the framing for how we think about buy versus build versus rent, and the framework with which we kind of made the decision on the infrastructure side. But great question.
Yeah, so basically on the back end, there's two sides of the organization here, right? Like for those of you from HCIT and from healthcare, like most plans will have the IT department, that's their technology department. We have our own R&D department, we build products just like a startup would. So we build a product that's Clover Assistant. We also have the tech stack, which is belonging to the plan itself, which uses InsurTech, claims adjudication, like all those kinds of things. There, we try to be very progressive as well. So for example, even on all of our plan tech side, we do not have any on-prem infrastructure, right? So nowhere in my entire Clover Assistant, all the way through basic plan tech, do we have on-prem, right? I think that's really, really powerful. We are cloud native throughout, right? What that means is that because we're cloud native, most of the technologies we use, if not all, we select them to be forward leaning, even if we're not going to build it. Like we don't build our claims adjudication system. We use health rules from Health Edge, right? But we still built a system where we can put this in the cloud. We don't have to run it on-prem. But we get systems which are API native so that we can pull data in and out of those systems because we know we'll want to. And then Clover Assistant's data infrastructure plugs into all of those areas so that we can pull it centrally into the Clover Assistant data layer, because everything might have signal in terms of how we give care. So we definitely do not build everything. Almost everything in Clover Assistant itself is built by us. That's our tech stack. We have patents, we have IP. And then all going to where we actually rent or we get from vendors, we always pick something which has API capability, interop capability, the ability to move data in and out, all using standards and all of those dimensions, so that we can pull data into Clover Assistant and manipulate that data as appropriate. We also have a big focus on omni-channel outreach and things like that. And that's where we're very progressive on the use of things like Salesforce, where once again, I don't feel the need to build my own CRM, but I'm on the Salesforce Product Advisory Council, and we push them and we use that platform to make sure that we're very advanced at how we are able to do sort of touch points to the CRM side of things. So IP generating, but in all areas, we are cloud native and extremely progressive in our tech selection.
Right. So when a physician enrolls, right, to be a provider in your plan, do they enroll right in Clover Assistant?
Yep. So basically they contract with us, and they can even contract within Clover Assistant if they want to, right? And then also what they can do is basically they create an account. We have single sign-on. It's our own identity layer that wraps Clover Assistant. All that account creation is within CA. They will also have their contract loaded into the claims payment system, because that's also needs to be there so they can bill generally. But all of that happens with an account creation, SSO, etc. through CA as well.
Right. And what do you do? Last question. Accreditation. Do you use a third party for that?
We use a third party for that. That's correct. That's on the plan side. We use a third party.
Okay. And then just maybe walk through a little bit on the framework on how you think about buy versus build versus rent, just generally speaking.
Yeah, so generally speaking, what we see is that we want to be an IP generating organization. So every area that has core differentiation for us, which is, there's a lot of places that is core differentiation, particularly in areas where we said before, we're doing something clinical and providing clinical capabilities. That's very interesting for us to have in our platform. Now, we are not going to run our own clinical studies, right? I am not in the business of discovering new clinical evidence-based protocols. That's not what we're doing. So our clinical team, Mark, Kumar, Sophia, is always there looking at clinical protocols, looking at evidence-based capabilities that we can then load into Clover Assistant. So the platform, ours, our IP. The ability to have engagement with physicians, that KPI, ours, our IP. Clinical content, we don't have to generate all of that content ourselves. We certainly load it into CA ourselves, but we can find those protocols through studies, through academic institutions, from best practices from that are out there. That sort of thing is not where we are focused, and that's something we can rent. We are also generally, like I said before, not in the business of building out what I would consider commodity technologies that could be sourced from modern SaaS companies, right? So if I can send it out to SaaS, I don't need to build it myself. There's plenty within CA that I can focus on.
Great. Thank you so much.
And then I know, Kumar, you had pinged me about a stat that I think you feel is really important to share, and I agree, around the video visit rate and around our more complex population, why having a high video visit rate is very important from a clinical perspective.
Yeah, so one of the things I think that's really important point to remember in Medicare especially is that not everyone in the Medicare age population has their own smartphone, has their own tablet, has their own computer with Wi-Fi. And we strongly believe that video-based clinical interactions are better than just phone calls. And that's especially important now in a situation of COVID, where it's not always safe to have a face-to-face in-person interaction. So the options are just calling somebody or having a clinical interaction via video. And video, it may be obvious, but I just want to indicate why, is better for a number of reasons. One is, as a clinician, as a physician, I can see my patient. I can build that therapeutic relationship, and that relationship builds trust. And that's critical to everything that I'm going to recommend. If someone doesn't see me, if they can't trust me as much, if they've never seen me before, it's harder for me to do my job. And that's just true in general. Second is that when you can see things, you literally can see how a patient is feeling. If they're breathing hard, if they have a wound, you learn more information about a patient. And one of the things that became critical in the situation of COVID, and in general, it's an important thing moving forward, is maximizing the percent of interactions that happen with Clover members between a provider and the patient that happen on video. One of the things Andrew mentioned is, and Sophia as well, within weeks of COVID hitting in February, March this year, we built a video platform directly within Clover Assistant that doctors use when they see our members. And not only is it built there, it's super easy for members to use. They literally just need to get texted a link or an email, they click on it, it launches. There's not all the other steps that are used with a number of other products. The other thing though we're doing is, as Andrew said, I just want to underscore this data point. for members who do not have access to video technology, so they don't have the hardware, they don't have connectivity, or even if they do, they don't have the comfort or know-how to use their device, we literally will send them a device. And whether that's, mailing or driving to them and delivering it to them, we're essentially allowing our members to have a white glove experience that they've never had before, where a clinical team has delivered technology to their door to enhance their interaction with a clinical provider. And, for one of our programs where we have nurse practitioners work with our members to do a comprehensive health review and then coordinate their care based on needs we identify, we're currently up to 90 to 95% of our interactions are on video within New Jersey. And that number it's actually insane how high that number is, right? And this is not a selected population that has video, knows how to use video. Clover, I think one of the things we pride ourselves in our origins in New Jersey is we're not afraid to go where other health plans don't want to go, right? And we're not afraid to be in Newark or Patterson or Trenton or Camden. Some of you people might know these areas of New Jersey where not everyone is well off, right? And we've found a way to make it work. And this is just really part of that ethos, which is we very profitably deliver technology that enhances clinical care and improves outcomes. And I think that's just sort of, and we've done that within weeks to months, right? From getting to, our native rate on video to 95%. And, to me, that's something we're really proud of because we value the interactions patients have with us. And we think the deeper and better those interactions, the better the clinical care, the better the outcomes. And I really think, stepping back, this group has probably spoken with a lot of payers over the years. I think one of the points to underscore is Clover Assistant and our technology platform delivering video. While there's a clear opportunity there to learn more about patients, understand diagnoses that are important because we do want to understand and know what patients have, there's real ability here to actually improve medical outcomes and lower medical expenses, which has not been the forte of payers traditionally, because that is much harder to do. And really the effort here is to do that in a scalable way through technology. And I think we're all proud. I know I can speak to for Sophia and Mark. We're really proud to be a part of a company where technology is actually being used to improve lives of patients and older adults.
Thanks, Kumar. And just, one thing to kind of note for everyone, and I'll hand it off to Whitney to close. Kumar, Sophia, Mark, and the rest of our clinical team, myself, Andrew, we spent a ton of time with them as they'll profess to. And so, for us, we are a clinical organization. So whether it's future earnings calls or calls, we just don't find it normal to have conversations, whether it be with investors or research analysts, without our clinical team. And one of our goals, just from an education perspective, is we'd love to play a role with research analysts and investors and actually educating individuals about the clinical side. We think, just having been an investor myself in lots of companies, there's not a lot of conversation shared with investors or on earnings calls or whatever it may be around clinical education. We think there's a lot of value to be gotten to dive deeper in all these aspects. To the extent anyone has a desire to, we obviously will talk about numbers all day long. We're happy to do that, and that's vital as a company. But to the extent individuals have goals of really understanding the clinical side, understanding why, identifying conditions earlier matters from a clinical perspective, how physicians think about that, why our home-based primary care program actually drives great outcomes and why we have strong views in terms of, how I view that versus brick and mortar care. To the extent that there's a desire for deep dives on that from a clinical perspective, we're very happy to do that. We think education around clinical initiatives and clinical value inures to everyone's benefit. And we think, to the extent we can play a role in ensuring all healthcare companies, publicly traded or otherwise, are held accountable on the clinical side, we think it's really important. So, to the extent anyone wants to do that, we welcome it.
Great. Thank you again, everyone, for joining us today and all of the great questions. We apologize we aren't able to get to the remaining few questions today, but we'll follow up via email with everyone and see if we can find a time for a follow-up session conversations with the team. And with that, that concludes our Analyst Day, and happy Thanksgiving to everyone, and stay safe.
Thank you. Happy Thanksgiving, everyone. Thank you.
Everyone.